네, 지금부터 한국노년학회가 주최하고 서울특별시가 후원하는 제16회 서울노년학 국제학술 심포지움을 시작하겠습니다. 저는 오늘 사회를 맡은 한국노년학회 총무이사 모건대학교 사회복지학과 이상우입니다. 만나서 반갑습니다. 오늘 심포지움의 주제는 포스트 팬데믹 시대 노인의 삶, 새로운 도전과 기회라는 주제를 가지고 심포지움을 열게 되었습니다. 먼저 우리 한국노년학회 이금용 회장님의 개회사를 들어보도록 하겠습니다. 박수로 환영해 주시기 바랍니다.
네, 존경하는 한국노년학회 회원 여러분, 그리고 이번 국제학술 심포지엄에 유튜브를 통해 참여하고 계신 여러분 반갑습니다. 저는 한국노년학회 32대 회장 이금용입니다. 코로나19 상황이 아직도 진행 중인 관계로 대면으로 직접 여러분들을 만나 뵙지 못해 아쉬운 마음이 매우 큽니다. 인구 고령화의 위기를 지진, 영어로 얼스퀘이크라 그러죠. 지진에 빗대어 에이징 퀘이크라고 비유하기도 합니다. 그런데 코로나19 팬데믹으로 인해 전 세계에서 경제, 사회, 문화, 복지, 교육, 가족체계 등 사회 전체가 흔들리고 있는 지금이야말로 저는 감히 바이러스 퀘이크라고 말할 수 있겠습니다. 우리가 일상으로 누리던 모든 것들이 달라지면서 새로운 환경과 생활 방식에 적응해야 했기 때문입니다. 우리 모두가 힘들었지만 이 바이러스 퀘이크는 특히 사회적 약자나 소외계층에게 더욱 가혹한 시련과 고통을 안겨줌으로써 우리 사회의 불평등을 더욱 가중시켰습니다. 특히 디지털 취약계층인 노인들은 사회적 교류와 활동의 제한으로 사회적 고립이 가중되었고, 돌봄의 공백으로 인해 노인들의 신체적, 심리적 건강이 더 악화되기도 하였습니다. 우리 학회는 팬데믹 상황에 대한 한국 사회의 대처 방안들을 재점검하고 향후 포스트 팬데믹 시기를 대비하기 위해서 포스트 팬데믹 시대 노인의 삶, 새로운 도전과 기회라는 제목으로 제16회 서울노년학 국제학술 심포지엄을 서울시의 지원으로 개최하게 되었습니다. 이 자리를 빌어 서울시장님과 관계자분들에게 진심으로 감사의 말씀을 드립니다. 본학회에서는요, 미국, 영국, 싱가포르, 홍콩, 일본 등 해외 선진국 5개 국가와 한국의 전문가들이 참여하는 국제학술 심포지엄입니다. 여기에서는 코로나19 팬데믹 기간 중 해외 선진국에서 시행된 정책과 사례들, 그리고 이후에 달라진 노인들의 삶을 소개하고 함께 논의함으로써 포스트 팬데믹 시대에 어르신의 삶의 질 향상을 위한 지방 정부의 정책 방안들을 모색하고자 합니다. 이번 학술대회에서 주제 발표를 해주시는 해외 연자분들과 한국의 토론자분들에게 학회를 대표해서 진심으로 감사의 말씀을 드립니다. 무엇보다 본 국제학술 심포지엄을 기획하고 해외 연자분들을 직접 섭외하면서 서울시의 지원을 위해 노력해 주신 우리 학회 대외협력 부회장이신 김기영 교수님께 진심으로 감사드립니다. 이번 국제학술대회는 올해로 임기가 끝나는 제32대 회장단의 마지막 행사입니다. 그동안 우리 학회와 회장단에게 따뜻한 관심과 응원을 해주신 학회 회원 여러분들께 고개 숙여 감사드립니다. 감사합니다.
네, 이금용 회장님께 개회사 말씀 감사드립니다. 다음으로 김상한 서울시 복지정책실장님의 축사가 있겠습니다. 김상한 실장님의 축사는 일정 관계상 직접 참석이 어려우신 관계로 영상으로 대체하도록 하겠습니다.
서울노년학국제학술 심포지엄 참여자 여러분 안녕하십니까? 서울시 복지정책실장 김상한입니다. 우선 2006년을 시작으로 올해 16번째에 16번째에 이른 서울노년학 국제학술 심포지엄 개최를 진심으로 축하드립니다. 2년 만에 다시 열리게 된 이번 심포지엄에 축사를 하게 되어 매우 기쁘게 생각합니다. 서울노년학국제학술 심포지엄은 그동안 국내외 노년학 전문가들의 다양한 의견 교류를 통해 서울시에서 어르신 정책을 수립하는 데 많은 해안을 제공해 주셨습니다. 이번 심포지엄은 미국, 영국, 홍콩, 일본, 싱가포르 등 5개국이 참가하고 노년학 관련 전문가와 학생, 실무자 등 150명이 참석하여 포스트 팬데믹 시대 새로운 도전과 기회로서 노인의 삶에 대하여 뜻깊은 논의를 나눌 것으로 기대됩니다. 팬데믹 기간 서울시는 직접적인 복지 서비스 제공이 위축되는 상황 속에서도 대상자의 건강, 상황에 따른 개인별 맞춤 돌봄 서비스를 운영하고 비대면 복지 서비스를 제공하는 등 어르신 복지 정책의 보완과 개선을 위해 노력해왔습니다. 오늘 다양한 국가들의 팬데믹 기간 어르신 복지 정책 현황을 공유하고 포스트 팬데믹 시대에 나아갈 방향을 함께 토론하여 어르신들의 삶의 질을 개선하는 정책 발굴을 도모하는 시간이 되기를 바랍니다. 서울시는 앞으로도 어르신 정책과 관련된 국제적인 의견 교류의 장을 확대하기 위해 노력하겠습니다. 마지막으로 귀한 자리를 마련해 주신 한국노년학회 이금용 회장님과 관계자 여러분, 발제와 토론을 준비해 주신 국내외 전문가 여러분, 그리고 모든 참여자 여러분께 깊은 감사의 말씀을 드립니다. 감사합니다.
네, 다시 한번 축사 감사드립니다. 자, 그럼 지금부터 본격적인 심포지움을 시작하도록 하겠습니다. 오늘 주제 발표와 토론의 전체 진행은 우리 학회 대외협력 부회장이신 중앙대학교 심리학과 김기현 교수님께서 맡아주시겠습니다. 박수로 환영해 주시기 바랍니다.
네, 안녕하십니까. 방금 소개를 받은 오늘 심포지엄 좌장을 맡은 대외협력 부회장 중앙대학교 심리학과 교수 김기현입니다. 반갑습니다. Good afternoon, everyone. I'm Giyeon Kim. I'm the Vice President of External Affairs at Korean Gerontological Society. I'm a professor and chair in the Department of Psychology at Chungang University in Seoul, South Korea. I'll be chairing this symposium today. First, I'd like to thank Seoul Metropolitan Government to fund this important symposium. And I'm very honored today to chair the symposium focusing on a new aging life in the post-pandemic era, which is a timely topic. It's an absolute pleasure. Welcome all of you joining us on YouTube Live. And I'll be using both English and Korean in chairing the symposium. 네, 여러분 안녕하십니까? 오늘 포스트 팬데믹 시대 새로운 도전과 기회로서의 노년기 삶이라는 시의적절한 주제로 시행될 심포지엄의 좌장을 맡게 되어 매우 기쁘고 영광스럽습니다. 먼저 오늘 서울노년학국제학술 심포지엄을 후원해 주신 서울시에 큰 감사를 드립니다. 더불어 이번 국제학술 심포지엄 개최를 위해 많은 도움과 지지를 보내주신 한국노년학회 회장 이금용 교수님 및 학회 관계자 여러분들께도 감사의 말씀을 드리겠습니다. 그리고 오늘 유튜브 라이브로 보고 계신 참여자 여러분들께도 감사드립니다. 오늘 심포지엄 좌장으로서 제가 영어와 한국어를 번갈아 사용하면서 진행할 예정입니다. So I'll be briefly introducing our symposium speakers and discussants. So we have 5 internationally renowned speakers from 5 countries, including the US, UK, Hong Kong, Japan, and Singapore. And we also have 3 expert panelists from Korea. 오늘 심포지엄의 연자와 토론자를 소개하도록 하겠는데요. 이번 심포지엄은 지금 보시다시피 미국, 영국, 홍콩, 일본, 싱가포르의 5개국의 연사와 그 다음에 3분의 국내 전문가 토론으로 구성되어 있습니다. 토론에 참석하기로 하셨던 이윤환 교수님께서는 오늘 건강 문제로 참석을 하지 못하셨고요. 자, 그럼 바로 다음 저희 첫 번째 발표자분을 간단히 소개드리고 첫 번째 발표 들어보는 시간을 갖도록 하겠습니다. So our first presenter is Dr. Corinne Phillips from United States. Dr. Phillips is currently a policy development manager at Trust for America's Health in the United States. Dr. Phillips received her PhD degree from the Aging Studies program at the University of South Florida, and she also received her bachelor's degree from Cornell University in the United States. So her presentation title is How Age-Friendly Public Health Systems Are Supporting Older Adults in the U.S. 오늘 첫 번째 발표는 닥터 필립스 박사의 미국의 사료에 대한 발표로서 필립스 박사의 발표 제목은 어떻게 고령 친화적인 공중보건 시스템이 미국 노인들을 지원하는지에 대한 발표입니다. 필립스 박사는 미국 코넬 대학에서 학위를 받았고 미국 남플로리다 대학교 노인학과에서 박사학위를 받았고 지금은 워싱턴 DC에 있는 Trust for America's Health 라는 기관에서 정책개발 관리자로 일하고 있습니다. Let us welcome our first presenter, Dr. Coran Phillips. 자, 그럼 첫 번째 발표자인 필립스 박사님의 미국의 사례에 대한 발표를 들어보도록 하겠습니다.
Looking for synergy, they were looking for opportunity. Greetings, I am Dr. Coran Phillips, and I will be presenting on how age-friendly public health systems are supporting older adults in the United States. So Trust for America's Health is the organization that I represent, and we are an independent, nonpartisan public health and prevention-focused organization based in Washington, D.C. I am a policy development manager, and I specifically work on the Age-Friendly Public Health Systems Initiative. Trust for America's Health overall, or as we call ourselves, TIFA, is focused on advancing evidence-based policy and advocacy with a keen focus on equity. We're deeply committed to improving the health of every community and making disease prevention a national priority. TIFA overall produces several great reports, some such as The Pain in the Nation that looks at the epidemic of alcohol, drug, and suicide deaths, and also, for example, the impact of chronic underfunding of America's public health system. So again, these are all reports that are produced by TIFA at large. And I would also like to acknowledge that our work on the Age-Friendly Public Health Systems Initiative is funded by the John A. Harper Foundation. So before we begin talking about how the age-friendly public health has been a part of helping advance healthy aging, let's talk a little bit about what the ecosystem is. Public health is a piece of this larger ecosystem of age-friendly efforts. And these age-friendly efforts are all best practices that help promote healthy aging. Our goal for the Age-Friendly Public Health Systems Initiative is to make sure that healthy aging is a core priority for departments of health. And public health is one piece of this. And we have age-friendly employers. We have age-friendly universities here in the United States. We have age-friendly health systems, again, having for example, geriatric emergency departments. And then we have age-friendly cities and communities. This is the AARP designation that cities and states can apply for to be known as an age-friendly community. So again, all these make up this ecosystem of age-friendly practices that support healthy aging. Public health is everywhere. These systems are everywhere. The Centers for Disease Control is the federal arm that focuses on public health. And here in the United States, there are 10 health regions, as you can see outlined in the graphic over on the other side of the slide. There are state-level health departments in all 50 states and the District of Columbia. There are territories also, in addition to the states, that have their own health systems. And then there are several other tribes that are also focused on health-related efforts. And then we have the local level health departments. It may look a little different in each state, but there are local level health departments, about 3,000 of them. So I'm not going to go in too much detail on this, but I wanted to just highlight and bring awareness to the 10 essential public health services. Again, these are designed, these are essentially the services that public health is versed in, and they're designed to protect and promote the health of all people in all communities. So public health is keenly able and keenly skilled at these 10 essential services. And this is what they bring to the table when they are engaged in an effort. So for example, public health is keenly engaged in assessment and monitoring of population health. I'll come back to why it's important in a little bit, but again, assessment and policy development, creating champions and implement policies, plans, and laws. And then around the insurance, enable equitable access. So again, these are the essential services that public health is committed to, and it's a framework that public health is committed to providing support to all people. We know that there are many health needs of older adults. Many older adults have at least one chronic condition, and quite a few have at least two, so comorbidities. They represent 82% of the Medicare spending annually. So we know that these are, again, it's just a snapshot, but we know that there are many health needs that we need to be aware of and figuring out how we can support older adults as they continue to age, and think about ways to help them age in healthy aging and healthy practices. So let's think a little bit about pre-COVID and where we are currently. So pre-COVID, it still has been a limited focus on public health, focus on older adults, largely because the assumption and the understanding, if you will, is that the aging sector, so organizations that specifically focus on older adults and have the expertise and historical knowledge of working with older adults, we're going to take care of the older adults. So pre-COVID, you have the CDC, they have the STEADY program, they have the chronic disease prevention programming, and then they have the Healthy Brain Initiative. So again, focused on falls, disease prevention, and Alzheimer's and dementia. Trust for America's Health, TIFA, is working on expanding CDC's role in healthy aging, but right now, the healthy aging branch is part of it's made up of several different components that we're working to expand and centralize under a healthy aging branch. The Department of Health and Human Services has a focus on older adults in the Healthy People 2030 now, but again, that's been after several years of increasing attention to older adults, or focusing on increasing the attention to older adults. But the key thing to note is that state and local departments of health in the United States lack funding to do a lot of things, and they have to prioritize what they focus on and how they focus on it. There also is a lack of coordination. People are doing different things across different organizations. Again, sometimes people don't know who's working on what project, and it could all be helping the same community, but it's disconnected and not coordinated. And then again, the departments of health don't necessarily have people that work for them that have expertise in working with older adults, or even just experience. So now we have a pandemic, and COVID became an unfortunate catalyst for a focus on older adult health, due to the exacerbation that we saw and the not only the disparities that we saw, but just the challenges that older adults were experiencing because of the pandemic. So we saw getting them access to vaccinations at home was a challenge, social isolation was a challenge, nutrition, physical activity, the list goes on. But it took a pandemic, as we often say, to bring full attention to this issue. But it was the catalyst that we needed to bring healthy aging up again as a core priority that people could start to see and understand how they can contribute to. So public health interventions for older adults, they're focused again on preventative and other quality health services. You have healthy, affordable food access. One of the things that was a result of the pandemic is many programs began to see how they could expand their reach to not just focus on children and families, but also people 65 and older. Specific activities, physical activities that focus on interventions for older adults, tobacco and substance misuse and prevention, social and emotional support. Again, social isolation was a challenge prior to the pandemic, and it continued to increase as a challenge, a significant challenge during the pandemic. Violence and abuse prevention, and then understanding how we could intervene and provide better infrastructure for social determinants of health, so housing, transportation, and the built environment. Our work for the Age-Friendly Public Health Systems Initiative is focused around a 6 C's framework, and this is our framework. It reminds you a little bit of that 10 essential services, but these are 6 C's. These are 6 areas that we are encouraging, and we help departments of health understand and see how they can, again, to support healthy aging through these efforts. So we started with 5, and then we added a 6 C recently, and I'll share which one that is momentarily, but we're focused on connecting and convening multi-sector stakeholders. One of the key things we know is that in order to support healthy aging, it involves different entities, and they all have to be brought together to support the health of older adults. So again, connecting and bringing everybody together to talk about what we need to do, what needs to be done. Coordinating existing supports and services. So someone over here may be doing something, someone over there may be doing something. How can we coordinate? How can we better align what we're doing to offer better services to older adults, maybe even provide a better access, and then again really start to address equity and really get down to people that need these services and supports. Collecting and analyzing and translating relevant data. As I mentioned earlier, public health is keenly able and very well versed in data access and analyzing data. So this is also key, not only in analyzing and collecting it, but translating it, getting it back to make it useful and understandable. Communicating public health, important public health information, making sure that messages are disseminated about what's needed to be done. For example, we have flu season, or we have different seasons, so making sure that messaging is out about different vaccine options. Complementing existing health promoting programs. How can we complement? How can we continue to work together on programs that already exist? So not reinventing the wheel. Again, as I mentioned in my previous slide, public health departments already have limited funding and limited bandwidth, so we have to keep it so that they are able to sustain and continue these health promoting programs. And then the 6th C that we added is focusing on creating and leading policy systems and environmental changes. This really, for us, speaks to having adequate leadership that can focus on that policy change and have a commitment to healthy aging. So again, we're focused on empowering and equipping departments of health to make healthy aging a priority, and this is all guided by our 6 C's framework. So I'm going to walk through a few states and where age-friendly public health systems is currently in place. So let's start with Florida. And actually, this work all began in Florida in 2018 with a pilot. And in that pilot, they developed aging in Florida profiles. You can see a snippet of one from Miami-Dade County in Florida. But these profiles actually highlight different plans that the counties had and worked on related to how they will make plans and make healthy aging part of their health department's goals. In Florida, this actually started with a convening, and in the convening, the leadership in the Department of Health Affairs and the leadership in the Department of Public Health never met. That was the first time they sat in a room together. So it was kind of an interesting moment because they were able to coordinate and start thinking about strategies. But again, prior to that meeting, they had never met. So we have these profiles for over 30 counties in Florida. And again, these are plans that they are creating to implement different efforts. So you can see with the green, those were the counties that were involved in the first phase. We're still working with Florida on this expansion, and in the expansion year, which is the current phase of our project, and getting engaged with more counties, but also continuing to support and encourage the work that is in the counties that we already have worked with in the first phase. In the second phase of this project, 2 states received sub-grant funding. So again, our funding is from the Hartford Foundation. We were able to provide 2 sub-grants, one to Mississippi and one to Washington State. So in Mississippi, they have one centralized Department of Health. So they only have one Department of Health at the state, but they have 3 regions. So the regions are shaded in the image on the screen. So they created a learning and action network of internal experts at the Department of Health, and they also have an advisory committee of external partners. And some of the members of their advisory committee are members of the Mississippi Department of Human Services, the State Union on Aging, Mississippi Access to Care Network, the Alzheimer's Association, AARP, the Mississippi Public Health Association, with Dr. Kate Bender, who is the immediate past president of the American Public Health Association, the Mississippi Department of Transportation, again, bringing in key stakeholders from different sectors, and the University of Mississippi Medical Center Division of Geriatrics. And they developed a really rich 6Cs framework plan that I'll highlight momentarily. And it was based around key principles of prioritizing equity, including community members, cultivating leaders, and building culture that fosters trust. So this is just a snippet of a very robust plan that they developed. And again, as you see, they have a goal where they talk about what they want to accomplish, and then they propose several different strategies to achieve the goal. So again, communicate and educate about healthy aging resources, and I'm just going to pick a strategy. Develop a speakers bureau to broaden and change the narrative on aging. So again, different strategies to talk about how they can continue to make healthy aging a priority across the state of Mississippi. And they created this really great infographic that they have been sharing to talk about some of the key issues and some of the key points to note in Mississippi about older adults. In Washington State, they created an advisory committee of external experts consisting of representatives from the Healthcare Authority, the Washington Area Association of Area Agencies on Aging, and Washington State University. They created a learning and action network. This consists of 5 teams of local health jurisdictions and area agencies on aging. So again, bridging the connection between the public health and the traditional, what we call aging sector. And they also actually were able to engage with tribes and have a consortium of 6 federally recognized tribes. They created healthy aging profiles for every county. And they're also beginning the initial discussions, and they just had it recently, a discussion about becoming an age-friendly community. So as I mentioned, that age-friendly community designation from AARP. So this is a snippet of one of their profiles. It shows, again, like the older population. It talks about specifically how many people in that particular county are 60 and older. Here's another one that talks about the chronic condition percentages in that specific county. And then some key things about subpopulations related to disability, cognitive impairments, etc. So in Georgia, we engaged in a very interesting project in partnership with the Association of State and Territorial Health Officers to develop a crosswalk where the state plan on aging was matched up with the state health improvement plan. So they were looking for connections, they were looking for synergy, they were looking for opportunities to, again, not necessarily reinvent the wheel, but to show this is where older adults is a part of what you're already trying to do. So again, you have this larger health improvement plan where the older adults already fit in, and how you can map that with these 2 very key documents to show the synergy, to show the overlap. This this work was actually turned into a paper and highlighted in a recent publication with our colleagues at, we call them ASTO. But again, this work highlights again where there is definitely synergy between the Department of Health and the Department of Aging. So again, this work was done in Georgia. And the action plan is leads to enhance focus on rural areas. That's what they learned from this crosswalk. Operationalizing state plans in a collaborative way, and then this could have an influence on future state plans. Knowing what they have learned from this analysis, this crosswalk, they can now have influence on what future iterations of these it could just be a plan, not maybe not even 2 separate ones, but either way, they now know that they'll have some synergy and much more influence on future plans. In Michigan, they're focusing on making a care journey and kind of an age-friendly everything. So they, again, the journey showing that kind of where you can access at any point and be able to be supported across the whole care continuum. So they brought all of these key organizations together, and they want to, again, make it a journey and make it so that you can access age-friendly anywhere. Wanted to highlight a project that we were engaged with in 2021 related to receiving at-home vaccinations. I think once we understood the nature of how vaccines were being distributed, a concern was raised about, well, if someone would like a vaccine, how are they going to get it if they are not able to leave their homes? And another part of that is, how do caregivers who are providing care, will they be able to get access? So we engaged in a project on access for older adults and people with disabilities who are homebound, and looking at who all is involved. What does it take to make sure that this is an equitable project, or not even project effort, but also who's involved, what kind of policies need to be in place, what about supplies? What we learned is that the short of the long is, there's a lot of entities involved. You can see each dot represents a key entity that had to be involved in the process. And it's a whole care map, if you will, involved with getting vaccines into communities. Who all is involved, who all had to be there. It's a lot of people. I always tell the story about a rural community that we learned about. In order to get vaccines to older adults in a very small rural community, it involved a snowplow, the Department of Health, the Department of Aging, I think maybe even local law enforcement, because they were snowed in. But again, they had to all coordinate these different entities to get the vaccines to that community. So again, our care map again just highlights all of the different pieces, like who all has to be there, who all needs to be a part of this discussion to make this happen. So again, it's a lot. It requires a lot of coordination, and it's not just one entity that can get it done. So if nothing else, going back to the earlier slide, the pandemic was a catalyst that highlighted a lot of challenges, but it was a catalyst to provide a lot of innovation and a lot of unique and necessary partnerships. So we also, again, wanted to focus on equitable access, focus on seeing the equitable access, prioritizing equity over efficiency. So again, there were stories across the country of people not going to get vaccines, but people, because they couldn't get to it. Not necessarily because they didn't want it. Again, they just couldn't get to it, whether it be they just were in areas that people could not access in certain communities, may not have public transportation to get there. We wanted to make sure we highlighted that. So there's a use there. We looked at social vulnerability index metrics for allocation decisions, social determinants of health, disability, race, ethnic language, ethnicity and language. Use leftover doses equitably. So again, you have leftover doses, make sure they are not wasted, and target neighborhoods of need. So again, that was part of what we learned from the different states as they shared their stories and how they proceeded with vaccine distribution. All this information is available on our website if anybody's ever interested. We have a brief that we produced about this project on vaccine access, and we also have a map that shows whether or not a state had a plan on vaccinating people that were at home. So it's an interesting exercise in learning what exactly was happening across the country. We were able to get a lot of information. So each state that is blue has information about whether or not they have a plan or not. A definition on homebound, that also was an interesting variable to examine as well. What was the definition of being homebound? How was being homebound defined? So again, all this information is available on our website. I'll make sure that is available to you all at the end. And here we go. Thank you all again for this opportunity to share a little bit about how age-friendly public health systems are helping older adults and promoting healthy aging in the United States. I have included my email address here. Happy and willing to answer any questions that you may have. Our website is agefriendlypublichealthsystems.org. We have a lot of great resources that some I mentioned, and some additional ones that I did not mention, but feel free to explore, reach out, and I have also included our large organization's website for TIFA. Thank you again for this opportunity, and I hope you all learn something new. Thank you.
Thank you for the very interesting presentation, Dr. Phillips. It was very helpful to understand how age-friendly public health systems are helping older adults and promoting healthy aging in the United States. 필립스 박사님 좋은 발표, 재밌는 발표 정말 감사합니다. 미국의 고령 친화적인 공중보건 시스템이 노인들을 돕는 방법, 또 건강한 노화를 증진시키는 방법에 대해 이해하는데 도움이 되는 좋은 발표였습니다. 자, 그러면 다음 발표로 넘어가겠습니다. Our second presenter is Professor Martin Hyde at Swansea University in the UK. Dr. Hyde is an associate professor in the Center for Innovative Aging at Swansea University in the UK. Dr. Hyde's main research areas are work and retirement in a global context. His presentation title is The Impact of COVID-19 on the Lives and Livelihoods of Older Adults in the UK. 두 번째 발표는 마틴 하이드 교수의 영국의 사례에 대한 발표인데요. 하이드 교수는 영국 스완지 대학교 노인학센터 부교수로 일과 은퇴를 국제적 맥락에서 보는 연구를 하고 계십니다. 하이드 교수의 발표 제목은 코로나가 영국 노인의 삶에 미친 영향입니다. Let us welcome our second presenter, Professor Martin Hyde. 자, 그럼 마틴 하이드 교수님의 영국 사례에 대한 발표를 들어보겠습니다.
Firstly, I'd like to thank the organisers for inviting me to come and talk about such an important topic. So my talk today will cover four main areas. Firstly, to give you a general overview of the impact of COVID-19 and a description of lockdown policies. Then to focus on the impact on mortality amongst older adults in general, and in particular those living in care homes. Then to look at the impact of the lockdown policies on a broader range of health and wellbeing outcomes, and finally to focus on the economic impact on older workers. To do so, I'm going to draw on a range of information across a number of studies using both quantitative and qualitative data to give a fuller picture of the impact that COVID-19 has had on older adults in the UK. So firstly, we can see two significant spikes in COVID cases, and we've had around over 20 million confirmed cases of COVID in the UK. In terms of mortality, we have two significant spikes again, the first being at the initial outbreak, if you like, of the pandemic in March 2020, and the second toward the end of that year and the start of 2021. Sadly, we've had over 200,000 confirmed deaths due to COVID in the country. In terms of vaccinations, we have quite a high rate of vaccination in the population, and again we can see this corresponds particularly to that second outbreak when there's a very high uptake of vaccinations. In terms of vaccination policy in the UK, the general population have been offered 2 vaccines and a booster by now, and certain groups in the population, particularly older adults, or including older adults, have been offered an additional booster as well, totaling 4 injections in all. In terms of lockdown policies, we had 3 major lockdowns, one at the start of the pandemic, one toward the end of that year, then a partial lockdown over the Christmas period of 2020, which was enforced in certain areas of the country which were deemed to have particularly high rates, and then a third lockdown in early 2021 when those partial lockdowns hadn't really had the desired effect. In terms of lockdown policies, people were required not to go out for anything that was deemed to be anything other than essential, and certain places were closed for the duration of those lockdowns: libraries, school, shop, gyms, so on and so forth. I'm not going to go through this slide in particular, but just to present this analysis done by the Institute for Government Analysis to show you the range of different policies that were enacted. So just to say that very brief overview masks a range of different policies, some that were introduced during lockdowns, such as the Eat Out to Help Out policy, designed to get people back into restaurants, and also detailing more about some of the partial closures during the Christmas lockdown of 2020. But this will be included in the slides for you to look at in more detail. In terms of how strict the UK lockdowns were, according to our Worldian data, they were relatively strict, particularly the second lockdown toward the end of 2020, start of 21. And in addition, in the UK, particularly during the first lockdown, where we were one of the number of countries that imposed particularly strong restrictions on older adults. So those aged 70 and over were required to stay indoors for up to 4 months during those lockdown periods. We've looked already at the impact of COVID on mortality for the general population, but breaking it down by age, we can clearly see that at all points, those aged 60 and over and 80 and over were at the most significant risk of dying. And if we consult the pie chart on the right hand side, you can see that well over half of all the COVID related deaths occurred in those aged 80 and over, with the other significant group being those aged 60 to 79. In particular too, we see a significant impact of mortality in care homes, mirroring the spikes that we saw for the general population and for older adults in general. So there were about 17% of all deaths in care home residents were attributable to COVID, so just over 45,000. And you can also see, particularly in the first wave, a steep rise in other deaths, so not directly attributable to COVID, but maybe due to problems in accessing healthcare for other health conditions. In terms of wider impact on health and well-being, particularly the restrictions on going out had a significant impact on people's mobility and movement. So here we see some statistics from the UK government, which shows a significant decline in the proportion of adults doing less physical activity than they did prior to COVID. And this is supported by a survey done by Age UK, which asked individuals to report the impact COVID has had on them. So we can see here people reducing their exercise, leading to other health complications such as weight gain or lethargy and sort of lack of energy and willingness to do stuff. This impacted on people's physical activity, although these data from the UK social survey show that older adults weren't any more or less necessarily impacted those in other age groups, but overall there are only about 60% of adults who are engaging in any sort of physical activity. And again, from the quotes from the Age UK survey, we can see that this has had knock-on effects in terms of aggravating pre-existing health conditions such as arthritis or Meniere's disease, and that inability to get out and about and move around having significant wider effects. These effects, or the UK government was particularly concerned about the longer term effects, particularly of reduced physical activity and its association with falls. So there was a decline in the number of people who were undertaking the recommended 30 minutes a day of physical activity, particularly in older adults. We can see the brown bars towards the right of the scale. So around about 30% of those aged 65 plus were not undertaking the recommended daily amount of exercise, and that this led to a considerable reduction in strength and balance, which in turn leads to an increased risk of falls and all the complications of further health effects, as well as additional demand on the health service that would cause. So there appeared to be significant spillover effects of the lockdowns that led to increased risk of poorer physical health amongst older adults due to their inability to get out and about. Also, I thought this was sort of interesting. It came up in the Age UK survey that people were also concerned about their ability to access the food or food at all, because in the first lockdown it was often very difficult to get to shops. People didn't know if they could go shopping. People were concerned about going to shops, and particularly older adults. Some shops would set up particular hours in the day that were dedicated just to older adults and people, other groups who were considered to be vulnerable. But that, I think, led also to a concern amongst older adults that going shopping was particularly dangerous. Again, looking at the UK UCL social survey, concerns about food security were very high for all groups at the start of lockdown and fell across the period as more shops opened and more places provided online delivery. But we can definitely see that it had an impact, particularly on older adults living with dementia, who were maybe unable to access the food that they normally would have, or do so in a way that was regular for them. Looking more broadly at the impact that COVID has had on psychological health, we have some data from the Understanding Society COVID survey looking at rates or proportions of people that report psychological distress during the period. Actually, what we see here is that those aged 55 and over, which is the oldest age group for which the data were reported, had the lowest levels of psychological distress. That said, when we look at the reports from the Age UK survey, we can see that COVID-19 did clearly have significant effects on that group of people for whom it impacted on them. So people feeling on edge, people feeling trapped, people feeling bored, people feeling stressed about the impact that the pandemic has had on them. Again, a similar picture when we look at anxiety. Again, the UCLL social survey suggests that older adults have the lowest levels of anxiety across the period, and that this doesn't seem to have been affected in any differently by the lockdowns as for any other age groups. But again, we see from the reports from Age UK that where it did have an effect, it was quite a profound effect for people losing sleep, people having sort of panic attacks, people feeling trapped, and pre-existing anxiety conditions returning because of COVID, particularly where people weren't able to access their usual social networks. Turning to look at more COVID-related stress rather than sort of anxiety in general, here we see from the UCL social survey that actually all age groups seem to have had relatively similar rates of COVID-related stress, and that they did respond to the lockdown. So we can see where lockdowns were put in place, as evidenced by the dotted lines, COVID-related stress went up. And in their report of their quantitative data, Age UK also reflect this, showing that people, older adults, were unlikely to leave their homes, fear that people weren't adhering to COVID-related restrictions, and therefore placing people at risk, as they had been told, and as we've seen from the data, that they were a particularly at-risk group. So the messaging around staying safe also appears to have triggered COVID-related anxiety for older adults, particularly those aged 70 and over. A lot was made in the press about the impact of COVID-19 and the lockdowns on loneliness, particularly in later life, with the assumption that older adults were going to be particularly hard hit because they were going to be deprived of the social networks that they would otherwise have. Actually, what we see from the Understanding Society survey, and which is also replicated in the UCL COVID social survey, is that older adults reported the lowest rate of loneliness. In fact, it was younger people who seemed to be most adversely hit. But if we think about this, they were taken out of school for during the lockdown periods, and many missed those socialisation experiences either at school or at university, when you would normally expect people in that age group to be mixing. So the expectations of social engagement and forming friendships were denied them. Whereas what we saw for older adults was often an uptick in engagement on online meeting activities, Zoom, email, Teams and the like, and lots of organisations shifted their activities to being online. That said, there's still around, well, still over 20% of older adults, probably close to 30% of older adults there, who said they felt lonely during the lockdown period. And again, you can see from the qualitative accounts that this impacted on a whole range of social activities, people feeling very much again cut off from their social networks, not able to go out and about and enjoy themselves. And again, particularly during those age-related lockdowns when people over 70 were particularly required to stay at home. So both my parents are in their early mid 70s, and they were both incredibly social people, and felt very frustrated that they were being told that they couldn't go out and do the sorts of things that they wanted to, which definitely led to feelings of low mood, stress, very much feeling like they were cooped up in their house. And we talked on the phone and we used Skype, Zoom, but at the same time it wasn't the same as being able to go out and drop into a neighbour's and get a cup of tea that they were used to doing. COVID-19, particularly during the lockdowns, as well as the stress that was put on the healthcare services, also created barriers to accessing healthcare. So again, the survey from the UK government found that around 50% of older adults didn't seek medical advice, often because it was very difficult to get access to a GP. GPs' surgeries were often closed. During lockdown, there was lots of traffic on the phone systems that made it difficult to get in touch. People also struggled to deliver healthcare into communities, again because of the social distancing, so people often had to sort of administer health through windows or in gardens, so they maintain a social distance from their clients, all of which was seen to be a concern in terms of backing up future healthcare problems because people weren't being able to get seen to in a timely fashion. And this particularly seems to have impacted those living with dementia or those caring for people living with dementia. So a recent scoping review that I was involved in found that COVID-19 clearly led to a reduction in support for people living with dementia, despite the move to more technological-based consultation practices and programs, and that this has had a negative impact on those living with dementia, their quality of life, and also their carers. And again, this was borne out in the survey responses in the Age UK survey, where again people who were often caring for people who were living with dementia felt that their symptoms had massively declined because they weren't able to get out and get the support as well as the social interaction that they ordinarily had. Also, people report, as this last quote suggests, is that people find it hard to understand why they couldn't meet with their friends and family. So people's sense of confusion also increased during this period. So finally, to move on to the economic impact that COVID-19 has had. So as of May, June this year, official statistics report that there are over 386,000 fewer economically active adults aged between 50 and 64 in the UK. So that's a huge number of people that have left or been pushed out of the labour market during COVID. So a survey from the Office for National Statistics shows that around a quarter of all 50 plus lost their jobs or left their job during the pandemic, and this seems to be particularly high for those aged 50 to 54 and 55 to 59. In terms of the reasons for leaving work, you can see that for the younger age groups, stress, mental health, being made redundant, having illness and disability were the highest reasons, whereas those aged 60 to 65 took, as well as some of those aged 50 to 59, took early retirement or felt pushed into taking early retirement. I think of particular concern is that almost a third of those who've left work during the pandemic said that it wasn't their choice to do so. So they were pushed out of work. And this seems to be particularly the case for those aged 50 to 54, where over 40% felt forced out of work during the pandemic. This seems to also have had a massive knock-on effect in terms of people's sense of hopelessness, feeling down. And again, this seems to be particularly the case for those in that 50 to 54-year-old age group, where we see over half reporting feeling down, depressed or hopeless on several days of the week, and a significant minority, just under 10%, feeling so every day. I think another issue is that people's, possibly as a knock-on effect of people feeling down, is that people therefore feel less inclined to contribute to or commit to or have the ability or resources to commit to other forms of social activity. So if we look at this, we can see that just under a quarter of those aged 50 to 54 who lost their jobs now say they plan to do less unpaid activity as a result or because of this. So that's another significant impact on activities being provided by older adults, paid or unpaid. So to conclude, it looks like COVID-19 had a somewhat paradoxical effect. On the one hand, the risk of mortality was clearly highest in the older age groups, but we can also see from the surveys that they seem to have been able to maintain the best levels of overall sort of well-being and health relative to other age groups. This could in part be, these findings could in part be due to methodological factors, because a lot of these surveys use online methods, and therefore certain groups of older adults might have been less likely to report those. But the Understanding Society data were collected from a nationally representative sample. So some of this is, we have to sort of understand as being real. Even so, it's clear that there's still a significant minority of older adults for whom the pandemic had a serious impact in terms of health and well-being, and we can see that from the quotes. And this seems to be particularly problematic for those who are living with dementia or those caring for people living with dementia. The long-term economic impact is also a concern, particularly because we know that older adults are less likely to be re-employed than younger adults, so those who have been pushed out might find it hard to re-enter the labour market, and there's significant evidence that shows that being forced out of work has long-term negative effects on health and well-being. So thank you very much for listening. I have a couple of slides with some links to what might be useful data or studies for you to follow up on. Hopefully these will be made available to you. And if you'd like to get in touch with me about this or anything else, please do so.
Thank you very much for the wonderful presentation, Dr. Martin Hyde. We were able to learn what COVID-19 did for older adults in the UK in terms of health and well-being. 영국의 사례에 대해서 좋은 발표해 주신 마틴 하이드 교수님께 진심으로 감사드립니다. 영국 노인들의 삶이 코로나로 인해서 어떻게 변했는지를 이해하는 데 굉장히 도움이 많이 되는 좋은 발표였습니다. 자, 다음 발표로 넘어가 보겠는데요. Our third presenter is Professor Terry Lam at the University of Hong Kong in Hong Kong. Dr. Lam is a Henry Leung Professor in Social Work and Social Administration and Associate Director of Southpaw Center on Aging in the Department of Social Work and Social Administration at the University of Hong Kong. His presentation title and his actually presentation focuses on a network of elderly centers supporting frail older adults during the COVID-19 pandemic in Hong Kong. 세 번째 발표는 홍콩에 계신 테리 럼 교수님의 홍콩 사례에 대한 발표가 되겠습니다. 테리 럼 교수님은 헨리 리옹 사회복지 및 사회행정 교수님이시자 홍콩대학교 사회복지 및 사회행정학과의 사우포 노화센터 부소장이십니다. 럼 교수님의 발표는 홍콩에서 코로나19 기간 동안 노쇠한 노인을 지원하는 노인센터에서의 관계망에 초점을 맞추고 있습니다. let us welcome our third presenter, Professor Terry Lum. 자, 그럼 세 번째 발표자이신 테리 럼 교수님을 환영해 주십시오.
Thank you for the invitation and giving me this opportunity to share, how we help older people in Hong Kong throughout the pandemic of COVID-19. Let me first share my PowerPoint. So I will divide the sharing into two sessions. In the first session, I will talk a little bit about how COVID-19 affects older people in Hong Kong. And in the second session, I will focus more on how a network of elderly centers help support frail older people in the community during the COVID-19 pandemic in Hong Kong. We did quite well in the first 2 years of the pandemic. In fact, we keep the infection number extremely low in Hong Kong. Very few people die because of COVID-19. Also, until summer of 2020, we did not have any nursing home outbreak in Hong Kong. And we were able to also protect older people in the community. So in general, older people feel quite safe, in Hong Kong at that time. Our story, our success story in the first 2 years also caught international attention. I was invited by the Parliament of the UK government to share our story, how the strict infection control measure in Hong Kong protect the older people in nursing home as well as in the community. Our story was also reported in major international newspapers such as the New York Times and Guardians in the UK, the Independent in the UK, as well as a few other newspapers in Europe and in Australia. We wrote up the story into a policy paper published in the journal Aging and Social Policy. Unfortunately, our system collapsed at the beginning of this year when we were hit by the Omicron. So if you look at the chart here, from January of 2020 until January of 2022, we have very low infection rate in Hong Kong. About only, for the 2 years, only about 10,000 people infected, and only a couple hundreds of people killed by the virus. But then within a month, the number jumped from a little bit over 10,000 to close to 1 million, people. In fact, as of today, we have more than 1 million people infected. The unofficial number is the infection rate to be 2 to 3 times higher than the official number. In this presentation, I'm not going to share why we move from a early success to a recent failure. I present my observation in an academic conference in London in September this year, so I'm not going to repeat here. Instead, my presentation today will focus on the role of a network of elderly community centers helping older people throughout the pandemic. Our success in the first 2 years mainly, come from the lesson we learned from the SARS pandemic in 2003. In 2004, the Hong Kong government published the first guideline on prevention of communicable disease in the residential care home for elderly. In that guideline, the government required all care home operators to designate an infection control officers to coordinate and to implement infection control measures within nursing home according to the guideline. During the 2003 SARS pandemic, we know that older adults were more vulnerable to SARS as they have both higher infection rate and a high mortality rate once infected. We also know that care home residents are particularly vulnerable as their risk of contracting the SARS virus was 5 times that of the general population. And most infections of care home residents were acquired through hospital visit. Therefore, cutting the transmission between hospital and care home should be an important defense to protect care home residents. We also know that a higher proportion of elderly SARS patients require intensive care and mechanical ventilation and had longer hospital stay, thereby increasing the burden on the healthcare system. So if we can protect the older people, particularly the nursing home residents, from the COVID-19 virus, we should be able to protect the healthcare system from collapse. And since both SARS and COVID-19 were caused by novel coronavirus, this lesson has been put into practice in Hong Kong from the beginning of the COVID-19 pandemic. So after the SARS SARS pandemic, the government published the guideline as I shared before, and the government also required all care home, the nursing home operator, to designate a person, to usually the nurse, to be the infection control officer. The government provides training to this person, but also require him or her to be the coordinator and implement such infection control method within the nursing home based on the guideline. Because of the experience with the SARS epidemic, once we know that there are outbreaks in China, the Hong Kong government put together a very intense surveillance system for infection in all incoming travelers and also in local community. The government isolated all infected patients in hospital for treatment, and all their close contacts are also quarantined in special quarantine facility for observation. Hong Kong government imposed a very strict travel restriction and ban, so no more foreigners were allowed to come to Hong Kong. We closed school. All teaching were converted into online teaching. The government also encouraged employer companies to allow flexible working arrangement for their staff. And the government prohibited a gathering of more than 4 people in the public. However, we did not have a total lockdown of the city. Life go on as usual with some restriction on gathering, on wearing face masks. Other than that, we did not have a total lockdown of the city. We also did not do large-scale testing in Hong Kong like those in mainland China. We did targeted compulsory testing of all close contact of confirmed cases, people belonging to high-risk group, and people within buildings with confirmed case. And examples of designated high-risk group included, test driver, public bus driver, staff in catering industry, staff of nursing home, and staff of gym and sports centers. The government, with the help of technology company, developed a GIS, Geographic Information System, to track all COVID-19 confirmed cases. So the dot here on the map show you where the cases are. So if we are living in area or district that has high concentration of confirmed case, then the government encouraged us to do more voluntary testing, and we also become more cautious, on personal hygiene. The government also documented detailed information on large outbreak cluster. So, for example, in here, I highlight the first nursing home outbreak in Hong Kong. So it was in a private nursing home. the outbreak was first confirmed with one case, but within a few days, more than 90% of all nursing home residents were infected. So at the end of that outbreak, 45 residents were infected with the virus. So because of the restriction or social distancing, government policy change, as well as the surveillance system, we were able to protect nursing home from having large-scale outbreak until 2022. And then we were also able to protect community during older people from the virus. Let me shift the topic on supporting community living older people throughout the pandemic. Hong Kong has a network of elderly centers. These centers are funded by the government and run by non-profit organizations. We have 41 district elderly community centers. So these are larger centers. Usually, they have social worker as their core staff. They also have nurse, have therapists, as well as other activity staff that run activities for older people. We also have 171 neighborhood elderly centers. These are smaller centers. They serve a smaller geographic district. And they have social workers as their staff, as well as activities organizer. However, usually in the neighborhood elderly center, they do not have nurse and they do not have therapists. So when you put the 171 and 41 together, we have 212 elderly centers in Hong Kong with 1.4 million older people. So it is about one elderly center per 6,849 older people. And these centers, they provide community support services to enable older people to remain in their community and to lead a healthy, respected, and dignified life. These centers, they also have large volunteer pool. Usually these are young old. They come to the center as a member. They participate in activities organized by the center. However, they also volunteer in the center. The elderly center, they are trusted by the community and also by the government. Most vulnerable older people in the community are either members of this center, or if they are not members, they are already known to the center. And the center usually have their contact phone number as well as their addresses. These are the type of services provided by the center. So they provide health education, case management. They provide outreach services and networking to support older people. They have a support team for elderly. So they also do a long-term care assessment for eligibility of government-funded long-term care services. They have voluntary developments. They provide care support services, education and supportive program on dementia. They provide social and recreational activities. They also provide meal and laundry services. So for example, a older person, singleton, lives by himself or herself, they do not want to cook. So they can come to the center for lunch and for meal. And the meal, the lunch and the dinner are subsidized by the government. They can also bring their dirty clothing to the center for laundry services. So the picture on the right-hand side are the activities organized within the center or by the center before the pandemic. So they have a board game. They have area that people can play mahjong or other type of cognitively stimulating activities. They have activities for craft. They have exercise class. So those are the typical services organized by the elderly center before the pandemic. The center staff, they know the district really well, and they also know the older people in the district. So after the outbreak, the center became the focal point of connecting vulnerable older people with resources, including, the face masks, disinfecting alcohol, medicine, or even food. Also, because they are they become a platform for, companies as well as individuals to donate their resources to help older people. So this elderly center, they receive a lot of donation from companies, from individuals. They also, become the center for distribution to distribute those resources to older people who are in need. So the picture here on the, on the bottom, a social worker in the center help to pack the resources into small bags, and so that, a volunteer, can bring those resources to older people in need. So during the pandemic, usually they will avoid face-to-face interaction. What they usually did was they put the package in small plastic bag in front of the door, and then they ring the bell. After that, they will walk away. They will stay about 10 meters to 20 meters, from the door, and they watch the older person to open the door, to come out, and to get the package. Sometimes they will shout to each other to exchange a few words, to say hi, and to ask about the well-being. Sometimes they would use the smartphone to communicate. So the elderly center were able to connect resources with people who need the resources. Also, in this elderly center, they have large number of volunteers. They also have program that that provides therapies for older people who have depression or other common mental disorder. Particularly, I want to highlight the JC Joy Age project, which is a project funded by the Jockey Club Charities in Hong Kong. The project provides geriatric mental health services to all older people through the district elderly center. In fact, most district elderly centers have social workers who are trained by the project to provide support as well as psychotherapy for older people with depression. Other than social workers who are trained to provide psychotherapy, the project also trained more than 3,600 older people as ambassadors. So the older person, the volunteer, they receive training on mental health first aid, elderly version, and they also complete a 8 to 10 hours practicum. After the practicum, they agreed to volunteer for a year to provide emotional support for older people who are facing mental health crisis during the pandemic. We also, the project also trained some ambassadors to make warm calls. We call it warm calls rather than cold calls because the person we call, the volunteer call, already known to the center. So the center have their address, the center have their demographic information, and have their phone number. So the ambassador, they were trained to use standardized instruments to screen for depression, anxiety, and loneliness among community during older people. They did 2 waves of tele-screening for older people. In the summer of 2020, at the beginning of the outbreak, they called 8,163 older people and screened for their mental health situation. In summer of 2022, after the big outbreak, in Hong Kong, they also called almost 5,000 people to complete the screening, the tele-screening. And any older person who were screened with high level of depressive symptom or anxiety symptom, they were referred to the social worker for follow-up services. These older people also organize themselves to run bottom-up community-based participatory project to promote mental health literacy amongst older people in their district. So the picture here are the small group of volunteers. So they have meeting each month to discuss how they can promote mental health literacy in their own community. When the outbreak become more severe, they use Zoom to conduct those monthly meetings. And in the monthly meeting, they organize activities for older people in their district. This is a community activity they organize. It was a face-to-face screening for older people in one of the districts. And this person with the blue mask, he was the volunteer. And he used an instrument to screen for depression. And for older people who have a mild to moderate level of depression, then they have QR code. The older person can use the smartphone to scan the QR code and then to connect to resources. And then this is another small group meeting. This group in another district, they developed a manual for older people to teach them how to handle their emotional stress during the pandemic. So let me summarize a little bit, on the COVID-19 and older people in the community. COVID-19 is not just a public health challenge, it is also a social challenge. At the beginning of the pandemic, many formal social services and healthcare services were being shut down or running at a significant reduced capacity. Volunteers in elderly centers were then mobilized to help vulnerable older people in their community. However, they need training. They also need support. Elderly center, other than volunteer services, they also become the platform, for donation as well as for distribution of resources for pandemic control, ranging from personal protective gears such as face masks, protective clothing, and disinfectant, to medical supply, to food. In Hong Kong, because we have such a network of elderly centers, it provides a very effective platform to support vulnerable community during older person in the community. So far, we were surprised how resilient these older people has been throughout the pandemic. And we hope after the pandemic, we could further enhance the network of elderly centers to build up the social capital within this elderly center and promote more mental health care within the center so that we have enough resources, social capital, to prepare the society for the potential next outbreak of pandemic. Thank you so much.
Thank you so much for the excellent presentation, Dr. Lam. It was very interesting and helpful presentation to understand the importance of the network of elderly centers to support frail older adults during the COVID-19 in Hong Kong. 홍콩의 사례에 대해서 굉장히 좋은 발표해 주신 테리 럼 교수님께 감사드립니다. 코로나 기간 동안 홍콩에서 시행된 여러 좋은 사례에 대한 정말 재미있고 도움이 많이 되는 발표였습니다. 자, 그러면 이제 네 번째 발표로 가보겠습니다. Next presenter is Professor Yasuyuki Kondo. Dr. Kondo is professor in clinical thanatology and geriatric behavioral science at Osaka University, Graduate School of Human Sciences in Japan. His presentation title is Reality of the COVID-19 Pandemic Impact on Older Adults' Life in Japan. 다음 발표는 야수유키 곤도 교수님의 일본의 사례에 대한 발표인데요. 곤도 교수님은 현재 오사카 대학의 임상 생사학 및 노인 행동과학 프로그램의 교수님이십니다. 곤도 교수님의 발표 제목은 팬데믹이 일본 노인의 삶에 미친 영향입니다. Let us welcome Professor 야수유키 곤도. 자, 그럼 발표자이신 곤도 교수님을 환영해 주십시오.
Hello everybody. My name is Yasuyuki Kondo from Osaka University. I'm very glad to have the opportunity to show our study and introduce this pandemic situation in Japan. The title of my presentation is Reality of COVID-19 Pandemic Impact on Older Adult Life in Japan. I would like to introduce several studies published already and also data from our own study. Here is the background. Under the COVID-19 pandemic, all people have been exposed to direct risk for infection of the virus and indirect risk to a normal lifestyle. So both risks would cause the short-term and long-term influence on health and well-being. Older people are believed to be highly influenced by those risks. For the short-term risks, that's true as indicated by the mortality ratio. But we are not sure whether older people are really vulnerable people and have strong impact from the situation. Today, I would like to present mainly two topics. First one is present the actual impact of the COVID-19 pandemic on Japan. For the second topics, to clarify whether our understanding of older people as vulnerable population is proper, I would like to introduce some published papers about Japanese situation and also would like to present our own result. This slide shows the cumulative data from 2020 to today about number of cases of COVID-19 infected patients and number of deaths by age groups. As you see here, and same as other countries, younger people have infected larger compared to older people, but number of deaths is larger in older people. And in Japan, the peak age of death is 80 years old. This might be the same to the peak death age of the people in Japan. This slide shows the confirmed weekly cases from 2020 to current days. And blue line indicate younger people under 50 years old and orange line indicate older people older than 60 years old. Upper line indicate actual number and downside figure show the percentage from the total confirmed cases for 50 years and younger and 60 years and older. In most of the cases, as you see here, younger people under 50 years and older people's confirmed cases are less compared to young. This graph shows the weekly death cases. Time window is same as this previous one, and as you see here, the death cases are larger for older people, red one, compared to younger through the whole period. I would like to show some topics under the COVID-19 pandemic in Japan. This picture shows old people singing at the karaoke room. In the earlier phase of the pandemic, karaoke room was believed to be one of the major places to have the cluster and spread of the infected cases. So for a while, these places were closed for older people, and recently these places are open for older people and they start singing again. The karaoke room for older people is a kind of social club, and they came in the daytime and sing a song and talk and laugh, and so this place is the very important place to have the social interaction for older people. So restarting of the karaoke room is a good news for older people. These slides show how to handle the meeting with family, people who live in an institution. This picture, the family member see the older people through the glass, and other use the film, and other use the video chat. But even though the institution try to handle the situation, it's very difficult to avoid the cluster at the old people institution, because many of younger workers have kids, and the kids bring the virus to the home, and workers get sick from the kids. From here, I introduce some papers indicating Japanese situation. First one is a longitudinal follow-up study of older people and see the relationship between living arrangement and social activity and physical activity. And the author shows that people who living alone and social inactive have the higher risk to be frail through the period. The graph shows the 4 lines, and bottom line indicate the physical activity level of the living alone and social inactive people. This study is very unique. See the relation between internet use and physical activity of older adults. And basically, use of internet is related to the higher physical activity. In the second analysis, they divided participants into 2 groups, social participated group and non-social participated group. And the results show that internet use influence physical activity level, especially for lower social participation group. So use of internet would be a compensation tool to be active. So even though they have social relationship, if older adults use internet, the social activity level, but not decreased. This study is the qualitative study for the daycare center users, and the authors show several difficulties from the daycare center users. Daycare center is the place for little bit frail older people to have activities. So for frail older adults, they complain a larger number of difficulties. From here, I introduce our own study. The data was collected as a part of the longitudinal epidemiology study that we are running for 10 years. The SONIC is the name of the project, named after the septuagenarian, octogenarian, nonagenarian investigation with centenarian. So we recruit larger number of people and also wide age range group and run the survey in 4 different regions in Japan. We collect data every 3 years for one age cohort, and our study was started in 2010 and followed till now. This table shows the total number of participants in each of 3 age groups for the first wave survey, and currently more than 3,000 participated and followed for years. We have successfully followed up participants till 2019 year's survey. This was the 4th wave survey for 70 years old cohort. But we could not run invitation type data collection in 2020 because of the COVID-19 pandemic. So we decided to run the mail survey to all participants in 2020 and 2021. Fortunately, we could restart invitation type survey in 2021. This was the 4th wave data collection for 80 years and 90 years old cohort. Here I present the data from the 2020 and 2021 mail survey. This figure shows the number of infected cases in Japan and the period of our mail survey. In total, we ran 4 mail surveys for youngest cohort group and 2 surveys to the older cohort. Sorry for this busy table. Upper table shows the participants of 4 mail surveys. We send mail survey to 70 years cohort. It means they are 80 years old at the 2020. And we send 2 mail survey to 80 years old and 90 years old group. And these are the number of participants. The first question to the participant is this: recognition of this paper. Do you know and do you refer the paper mentioned? And the paper was released from the Japanese Geriatric Society, March 2020, and spread through the local administrators or several different resources. And we ask this question to 80 years and 90 years old, and more than half of the participants know the paper, and some are not referring the paper, but most of the participants referring the paper. They already read the paper and try to avoid the inactive life and to be active. This figure shows the COVID-19 anxiety for men and women with different age groups. For 70 years old, we have 4 surveys, and for 80 and 90 years old, we have 2 survey periods. So the question item is just one item, asking, do you feel anxious about COVID-19 virus? And most of the participants say yes, they feel anxious, higher the anxiety high. But interestingly, the younger cohorts show the higher anxiety compared to older age groups. But the anxiety level of older age groups increased in a later survey. And also, women show the higher anxiety compared to men. We also check whether social interaction mediate the COVID anxiety. As shown in the figure, women have higher indirect interaction compared to men, and also indirect interaction have effect to increase the anxiety level. So indirect interaction indicate use the phone or not face-to-face interaction. But direct interaction have the effect to decrease the anxiety. So in this situation, meeting face-to-face might cause the good influence on the emotional state, especially for women. Interest result here is about the subjective economical state. The subjective economical states improve through the COVID pandemic period. Probably they have less chance to use money, so the subjective economical state improved. This is interesting result. We also have the publication about the behavioral change of the older people under the pandemic period. Our longitudinal study showed that compared to the 2019, before the pandemic, the frequency of exercise and frequency to meet people increased during the pandemic period. Probably older people know the information to avoid frailty. To be active is important, so they intended to be active under the pandemic period. This is not published yet, but this data show that the frequency goes out, decreased in the earlier phase of the pandemic, but gradually recovered. Probably the decline here are caused by the winter season. And frequency of exercise is increased and stable through the period. Also, the well-being decreased in the earlier phase, but recovered again. This is the data of the WHO-5 mental health questionnaire and also the life satisfaction. There seems to be a delay of the decline of life satisfaction. Probably it's a long-term effect, but recovered gradually. To summarize, COVID-19 pandemic caused a wide range of negative impact for older population in Japan. That's true. They are restricted to be active, both social, private, and leisure activities. But negative impact was stronger in frail older adults. Death rate, frailty, and social inactive cases. But healthier older people seem to be compensated for somehow. Even close of karaoke place, they improved the frequency go out, increase the number of meeting people. Longitudinal data show the impact was larger in its earlier stage for younger participants. In our study, around 80 years old people have strongest impact in the earlier phase, but gradually recovered mentally and physically. Probably for healthier older people might be resilient to the hard situation like COVID-19 pandemic. Thank you.
Thank you for the excellent presentation, Dr. Gondo. It was very helpful presentation to understand the reality of the impact of COVID-19 on older adults in Japan. 일본의 사례에 대해서 좋은 발표해 주신 야수유키 곤도 교수님께 감사드립니다. 코로나 팬데믹 기간 동안 일본에서 시행된 여러 좋은 사례에 대한 정말 재미있고 도움이 많이 되는 발표였습니다. By the way, there was some small beeping sound during the presentation. Thank you so much for understanding the beeping sound during the presentation. 중간에 잠깐 작은 소리가 섞여 있었는데요. 발표 중간에 조금 이해해 주셔서 감사합니다. 자, 그럼 이제 마지막 발표로 가보겠습니다. So our next and the last presenter is Professor Angelique Chan. Dr. Chan is an associate professor at Duke NUS Medical School in Singapore and in the Department of Sociology at the Duke NUS Medical School as well. She is also executive director of the Center for Aging Research and Education. Her presentation title is The Impact of COVID-19 on Older Adults in Singapore, Lessons Learned. 자, 마지막 발표는 앤젤리크 첸 교수님의 싱가포르 사례에 대한 발표입니다. 첸 교수님은 듀크 NUS 의과대학의 부교수이시자 사회학과의 부교수이시고요. 노화 연구 및 교육센터의 상임이사이십니다. 첸 교수님의 발표 제목은 코비드-19이 싱가포르 노인들에게 미친 영향과 교훈입니다. Okay, so let us welcome our last and the fifth presenter, Professor Angelique Chan. 자, 그럼 오늘 심포지엄의 마지막 발표자이신 안젤리크 첸 교수님을 환영해 주십시오.
Good morning. My name is Angelique Chan, and I am an associate professor at the Duke NUS Medical School in Singapore and in the Department of Sociology at the Duke NUS Medical School as well. I'm also executive director of the Center for Aging Research and Education, and today I'd like to discuss with you COVID-19 and its impact on older Singaporeans, lessons learned. I'll go through how Singapore dealt with the pandemic when it arrived on our shores, and then I will discuss some of the research that we have done on the impact of COVID-19 on older persons. As many of you know, Singapore is one of the fastest aging Asian countries. If you look at the graph on the right-hand side, you'll see that Singapore is aging faster than China, Indonesia, Malaysia, or the Philippines by comparison. And currently about 18% of our population is aged 60 and above. By 2030, 1 in 4 will be aged 65 and over. And the COVID-19 pandemic did have significant impact on the social and health well-being of older persons. So today I will go through lessons learned from the previous outbreak, government responses to COVID-19, the effect of COVID-19 policies on older adult health and mental well-being, and then pose a question: are older Singaporeans ready to live with COVID-19, and what can we expect as an outcome of the pandemic that started in Singapore in February 2020. One of the things Singapore had in terms of advantage was historical experience with outbreaks that could lead to pandemic proportions but didn't. This includes the SARS outbreak in 2003 and the H1N1 outbreak in 2009. What did we learn from the SARS outbreak? We learned that we needed more isolation facilities, better control in hospitals in terms of segmenting infectious patients. And these are some of the changes that Singapore made to their healthcare system in case another pandemic occurred, which it did. At the time, after SARS, all hospitals, public hospitals, extended their fever and isolation facilities in the emergency departments. And there was a stockpiling of 3 to 6 months of personal protective equipment and powered air purifying respirators for all hospitals and clinics. New infection prevention and control measures at all hospitals were heightened, and new standards created. For example, no inter-hospital movement of doctors, healthcare workers, or patients during a pandemic. Singapore government also developed DORSCON code, a disease outbreak response system condition, to characterize threat of the pandemic to the public. Color codes range from green to red, indicating a high public health impact. Singapore's first case of COVID-19 was detected on 23rd of January 2020. On February 2020, DORSCON level was raised from yellow to orange. And as you can see on the right-hand side of this chart, the DORSCON level orange refers to the disease being in the population but under control. It also restricts movement, and these were the rules essentially for a large part of 2020 in Singapore. They also set up a multi-ministry task force, including the Ministry of Health, the Ministry of Defense, and the Ministry of Home Affairs, because later on, the Ministry of Defense would be critical in deploying Army to help with vaccinations of the public. So perhaps the most significant period, the one that has stuck in everyone's mind during the pandemic, is what we refer to in Singapore as the circuit breaker period that ranged from April 7th to the 1st of June. It was during this time that the number of COVID-19 cases were increasing dramatically, and hospitals were having to deploy healthcare workers and also ramp up the use of external resources such as public parking lots and our convention center for beds for patients who were recovering from COVID-19. Now, what this period coincided with, or what it meant, was that essentially individuals were not supposed to leave their homes unless they had to buy food, seek medical attention, or provide help to someone who was unable to leave their own home, for example, older adults. Older adults in general, and this was in the newspapers and on TV and on the radio, they were highly encouraged to remain at home by both the government and their families. In nursing homes, older adults were not allowed any contact with family, and health care workers at nursing homes were required to live in temporary housing. So every night they would go home to a hotel room rather than their own families. So this represented a period of great disruption. People were anxious, people were worried, they didn't know what was going to happen. And older adults in particular were left stranded in nursing homes, or those living alone were primarily left alone, in many cases where they didn't need individuals to come and provide aid to them. So as I mentioned earlier, during the circuit breaker, you were only allowed to enter an older person's house if you were delivering essential goods or services, providing assistance, or seeking to render help in an emergency. Other than that, you were not allowed to have contact with older family members, and this, as you'll see later on, led to a lot of distress. One of the things that the government did to look after Singaporeans during this pandemic was to put aside a total of 6 billion Singapore dollars in the budget in 2020 for stabilization and support, and care and support. So they foresaw a need for increased budget to take care of the economy, individuals, and older adults living in the community. At the same time, we were studying older adults' use of technology and the digital divide. This was a paper that came out in 2020, and we were seeing that basically older adults were less likely to use technology as they became older. So the oldest old were the least likely to use technology. And when they did use technology, only about 43% used it to send text messages, 32% used it to get online with social networks to read or view content, and about a quarter, 28%, used it for internet and video calling. Only about 13% of older Singaporeans used the internet on a phone, tablet, or computer to get information about their own health or to manage their health conditions. And this was when we asked them in the last 1 month. And even fewer older Singaporeans, 7%, used a phone or tablet app to get information or help manage a specific ailment. So we saw very low use of technology among older persons. Now, if just to go back to the Singapore's timeline of reopening after COVID, on June 2nd, 2020, right after the circuit breaker, Singapore enters phase 1 of reopening. And people from the same household can visit their parents or grandparents, but only in groups of 2. As of June 19, we entered phase 2, and the limit expanded to 5. And households could receive 5 visitors at any time. By December 28, 2020, phase 3 of the reopening began, and group size limit was expanded to 8. Currently, we no longer have any group size limit, and we've moved into a phase of safe reopening that I'll discuss in a minute. Phase 3, where we are now, is a new normal for Singapore, where we treat COVID-19 as endemic. Social, cultural, religious, and business gatherings have resumed. Seniors have resumed their day-to-day activities, but there's caution. Safe distancing measures are still practiced, especially during peak period travel in crowded places, and individuals are encouraged to avoid large groups. Although we are now in a period where COVID-19 is considered endemic, there is still a lot of caution around allowing older adults to interact with the community. If you look at this slide, you'll see that just recently, from the 14th of October 2022 to the 10th of November 2022, the government clamped down on access to nursing homes because there was a recent rise in the B4, B5 variant of COVID cases in the community. And safe management measures at all hospital wards and residential care homes were tightened for 4 weeks. So older adults remain a vulnerable population as Singapore accepts that COVID-19 is endemic. And what this has done is it's created more intense attention on older adults, viewing them as vulnerable. And in some cases, the outcome is that older adults begin to see themselves in less positive ways as being particularly vulnerable to disease, and there are mental and physical consequences due to restricted mobility. So what kind of work did we do when COVID began? This is a piece that was led by Professor Sun at Duke NUS Medical School, looking at the impact of COVID-19 on well-being and different modalities of care. So what we did here was we conducted a qualitative study of patients with multiple chronic diseases who were attending specialist outpatient clinics at Singapore General Hospital, which is the largest hospital in Singapore and looks after about 50% of the Singapore population. The N was 91, the mean age was 62 years, and the sample was 68% Chinese and 62% male. Interestingly, we found no significant differences by age in the impact of COVID-19 on the management of chronic diseases. Here, I think it's due to sample selection. These were people who made it into the clinic and were obviously trying to manage their chronic conditions as the pandemic was ongoing. However, older adults in the interviews did express difficulty using teleconsultations to manage their chronic diseases. That's why they were in the clinics physically. And they also reported delaying appointments until absolutely necessary when their medication ran out. In another study that we did at the same time, we looked at the stakeholders, the hospital representatives, policy decision makers, and we asked about how they felt during this time of crisis in terms of the ability to provide care, and what would their suggestions be for improving health system resilience to prepare for future pandemics. We had a purposive sample of 51 stakeholders involved in care of non-COVID patients and or policy planning for chronic disease management. And in summary, they said that the optimal provision of care for chronic diseases was compromised during the pandemic because of a lack of direct communication between colleagues in clinical cases, resulting in a rescheduling of patients' visits. There was an uncertainty in diagnostic decisions because protocols were revised and labs were closed. There was limited preparedness to handle non-COVID patients' emotional reactions. So again, the anxiety and the worry, the fear that came with patients who were seeing doctors for their non-communicable chronic diseases. And then lastly, although various digital innovations enhanced access to care, there really was a digital divide and uneven digital literacy, such that older adults were not digitally savvy and perceived a lot of data security risks, which lowered their probability of using digital technologies such as teleconsultations. The data from Singapore General Hospital did show that there was an increase in use of telehealth in the general population and in the geriatric population. So if you look at the right-hand side, you'll see two graphs. The one on top is the geriatric in-person visits versus teleconsults. The in-person visits are the blue line and the teleconsults are the orange line. And what you'll see is during the lockdown period, there was a significant decrease in teleconsults and a significant decrease in in-person consults and a significant increase in teleconsults, reaching almost 45% during the period of partial lockdown. We saw the same trend for general medicine. The positive side was telehealth services were very rapidly extended to include a variety of healthcare services frequently used by older adults. This included social work consultations with psychologists, dietitians, therapists for rehabilitation, case managers, and nurses. But we were only reaching about 45% of the geriatric population. Another positive with the teleconsults was that it allowed for greater convenience and even conferences with family members who may not have been involved previously in the care of the older adult. Research in Singapore also showed the impact of COVID-19 on loneliness of older persons. Loneliness increased significantly during the lockdown period, as can be expected. Additionally, depressive symptoms decreased. There was a decrease in physical activity, a report of greater financial problems, and males, Indians, and those living alone were all more likely to report being lonely during the lockdown and partial lockdown. A total of 37% and 20% of participants reported decreased physical activity and had financial problems during the lockdown, respectively. We know that loneliness has a very detrimental effect on one's total life expectancy, and in previous work we've shown that at age 60, 70, and 80, being sometimes or mostly lonely can generally result in a shortfall of total life expectancy. We see that lonely adults at age 60 have a shorter life expectancy by 5 years and a shorter healthy life expectancy by 6 years. Therefore, the need to identify and manage loneliness is an important topic and has become an even more important topic now that COVID-19 is endemic in our society, and there are still residual worries about contracting the disease among the older population. So what are some of the things that we did in terms of outreach to isolated older people in Singapore? Our Prime Minister indicated that what makes Singapore different from other countries is that we have confidence in each other. We feel that we are all in this together and we do not leave anyone behind. This statement was made on the 20th of March 2020, just before lockdown, and the idea was that we would, to our best ability, use digital means to keep older adults company during this period. Since June 2020, Singapore has had a Seniors Go Digital program launched, where more than 1,000 digital ambassadors at that time were deployed to reach out and engage more than 36,000 older persons to teach them how to use digital technology, whether it was just for social interaction. As you can see here in this video, the older persons were interacting with their daughter or granddaughter over cooking. And the policies to encourage seniors to go digital have been ongoing, and the use of health technology has increased after the pandemic period and continues to increase during this period of COVID-19 being endemic. Now, the thing that we worry about is the following, and this is what I'll leave you with in the last slide, is the next impact in the aftermath of COVID-19. So let's take a little bit of time to look at this graph. If you start with the purple line or the pink line, the first wave of the pandemic resulted in immediate mortality and morbidity. And it took some time to bring that down. So you look at the first wave tail and post-ICU recovery, but we did bring it down. The second wave of the pandemic effect was the impact of resource restriction on urgent non-COVID conditions. So we saw about 41% of older adults delaying their non-urgent surgical procedures, for example, or delaying physical therapy. So what effect does that have over the longer time period? The third wave or impact of COVID-19 is the impact of interrupted care on chronic conditions. If you remember earlier, I talked about a certain fraction of older adults going into clinic and about 45% using digital technology to manage a chronic condition, which leaves more than half without having managed their chronic conditions during the period of lockdown and partial lockdown. And there are the long-term effects of that. And finally, what we refer to as the fourth wave or the ripple effect of the pandemic is the psychic trauma, mental illness, economic injury, and burnout that the larger population does feel, and is especially so among older persons. So even though COVID is now considered endemic within the Singapore population, there's a lot of work that still needs to be done to address these different waves, these different consequences over the long term in terms of health and social care of our community and of older adults, particularly in cases where they are isolated. We continue to work on this in Singapore, and we also look to other countries for best practices. So this is where I'll leave you today, and I look very much forward to the question and answer session. Thank you.
Thank you so much for the excellent presentation, Dr. Chan. It was very helpful to learn from Singapore's case. 싱가포르의 사례에 대해서 좋은 발표해 주신 앤젤리크 첸 교수님께 다시 한번 진심으로 감사드립니다. 코로나 기간 동안 싱가포르에서 시행된 여러 좋은 사례에 대한 도움이 많이 되는 발표였다고 생각합니다. 자, 이제 심포지엄의 발표는 모두 끝났고요. 자, 그럼 이제 토론 세션으로 가보도록 하겠습니다. So we are done for the presentations from the 5 speakers today. So we very much appreciate all 5 speakers from the US, UK, Hong Kong, Japan, and Singapore. We are now moving to the discussion session. So we have 3 expert panel discussants. So Dr. Hong-Soo Kim at Seoul National University, Dr. Yong-Ho John at Incheon National University, and Dr. Seon Won at National Assembly Research Service. So one of the discussants, Professor Yoon-Han Lee, was not able to make it today due to his health conditions. Each discussant has about 20 minutes for their discussion. And like me, our discussants will be also presenting both in English and Korean. 발표해 주신 지금 5개 국가의 연자분들께 진심으로 대단히 감사드립니다. 자, 이제 토론으로 넘어가 보도록 하겠는데요. 이번 심포지엄에서는 3분의 전문가를 모시고 토론을 진행하도록 하겠습니다. 3분의 토론자 선생님들께서는 서울대 김홍수 교수님, 인천대학교 전용호 교수님, 그리고 국회 입법조사처의 원시연 입법조사관님이십니다. 저는 다시 한번 말씀드리면은 중앙대학교 심리학과 교수 김기현입니다. 이번 심포지엄의 좌장을 맡았고요. 앞서 말씀드린 대로 원래 참여하시기로 하셨던 이윤환 교수님께서는 오늘 건강 문제로 참석하시지 못하셨습니다. 빠른 쾌유를 빌고요. 자, 각자 지금 토론자 선생님들께는 20분 정도의 시간을 드릴 예정이고요. 저와 마찬가지로 3분의 토론자 선생님들께서는 영어와 한국어를 사용하시면서 토론을 진행해 주시겠습니다. 자, 그럼 첫 번째 토론자 선생님 한번 모시겠습니다. So our first discussant is Professor Hong-Soo Kim. Dr. Kim is a professor in the Graduate School of Public Health at Seoul National University. Professor Kim is currently out of country, so she's not in Korea. So she will be joining us via Zoom for discussion. 우리의 첫 번째 토론자는 서울대학교 보건대학원 교수 김홍수 선생님이십니다. 김홍수 교수님께서는 현재 지금 해외에 계시는데요. 그래서 줌으로 이렇게 토론에 참석하시게 되셨습니다. 자, 그러면 김홍수 교수님 잠깐 모시고 이야기 들어보도록 하겠습니다. So let us welcome Professor Hong-Soo Kim. 자, 김홍수 교수님 지금 여기 나와 계신데요. 김홍수 교수님 안녕하세요.
네, 안녕하세요, 교수님.
네, 해외에 나가 계신데도 이렇게 또 흔쾌히 저희 토론 맡아주셔서 대단히 감사드리고요. 자, 그러면 간단하게 인사 나눠주시고 화면 공유해 주신 다음에 토론 진행해 주시면 되겠습니다. 그럼 준비해 주세요, 교수님.
네. 화면 공유할 수 있게 해주십시오. Thanks for the wonderful presentation of all the speakers. I have learned a lot today. I have prepared my slides for discussion in English for speakers who are attending this session, and will do my presentation in Korean, as almost all attendees of this symposium will be Korean colleagues, I believe. 저는 세 가지 토론의 포인트를 갖고 왔습니다. 첫 번째는 오늘 그 발표하신 5개 국가 그리고 한국을 포함한 6개 헬스 시스템의 그 코비드의 영향 그리고 코비드에 대응하는 정책의 그 강도라고 할까요? 엄격함이 이제 차이가 있다는 것을 먼저 말씀을 드리고 싶습니다. 5명의 발표자는 각자의 시스템에 대해서 얘기를 했기 때문에 우리가 들을 때는 그것들이 어떻게 실제 코비드의 영향이 어느 정도였고 또 그 대응들이 어떠했는지를 사실은 알기가 좀 쉽지 않습니다. 그래서 그것을 좀 보완하기 위해서 이 토론에서 첫 번째 포인트에서는 아웃월딩데이라 많이들 아실 것 같은데요. 옥스퍼드 유니버시티에서 만든 웹사이트입니다. 코비드와 관련된 많은 통계들이 여기에 잘 정리되어 있고요. 이것을 가지고 제가 첫 번째 토론 포인트를 만들었습니다. 다만 주의하실 거는 이 첫 번째 포인트는 전체 인구에 대한 겁니다. 그래서 노인 스페시픽하지 않지만 이것이 오늘 토론에 이제 많은 그 뒤에 2가지 토론 포인트들을 배경이 될 수 있으리라 생각합니다. 첫 번째 보시는 이 화면은 그 한국 포함한 6가지 헬스 케어 시스템의 이제 코비드-19 케이스, 컨펌 케이스입니다. 그러니까 어느 정도 코비드-19 환자가 발생했느냐입니다. 이게 per million people로 되어 있기 때문에 비교 가능한 컴패러티브 스타티스틱스입니다. 보시면은 지난 약 2년 반 동안 그 초반에는 이 핑크색 유나이티드 킹덤이 핑크, and 유나이티드 스테이츠는 그린, 그렇죠? 핑크와 그린으로 되어 있는 이 미국과 영국에서 굉장히 많은 발생이 있었고요. 근데 올해 초, 그러니까 겨울에 들어서는 이 국가들도 여전히 높지만 한국과 홍콩이 아주 높은 발생을 보였습니다. 한국의 경우는 아마 다들 아실 거예요. 그 정부가 굉장히 강력한 코비드 방역을 하다가 이 시점쯤에 그 주 코비드 베리언트가 변이가 오미크론으로 바뀌면서 정부가 그간에 이제 강도 높은 방역을 계속하는 것에 장점과 단점, 비용과 효과를 다 따져보고 여러 가지 것들을 봤을 때 조금 치명률이 낮은 오미크론으로 바뀌는 시점에서 방역의 강도를 낮춥니다. 그게 정확히 높은 그 코비드 발생으로 이제 나타났고요. 흥미로운 건 아까 테리럼 그 교수가 이 시점에서 자기들이 잘 해왔다가 높아졌다고 하는 거 얘기했을 때 그게 도대체 어느 정도 높은 것인지를 이 슬라이드를 보면 아실 수 있습니다. 그래서 굉장히 많이 발생을 했죠. 그 이후에 또 이게 이제 일단 떨어졌지만 다시 이제 한국도 그렇고 올라가는 추세에 있는 걸 보실 수 있습니다. 두 번째 슬라이드는 사망입니다. 코비드로 인한 사망 컨펌 케이스인데요. 이것도 역시 마찬가지로 앞에 보시면 작년 말까지는 미국과 영국, US, UK 두 나라가 굉장히 많은 그러니까 사망 발생이 있는 걸 아실 수 있습니다. 비해서 아시아 국가들은 굉장히 선방을 한 것이죠. 이 숫자로만 보면. 그리고 흥미로운 거는 이 2022년 초, 그러니까 이번 겨울을 앞두고서는 앞에 보신 홍콩의 높은 발생률에 거의 대응하듯이 한국에서는 굉장히 높은 사망이 또 발생했습니다. 반면 한국은 높은 거에 비해서는 높아지긴 했어도 이 한국인데요. 그다지 높지 않은 홍콩에서는 꽤 잘 컨트롤한 걸 아실 수 있습니다. 그래서 이런 차이들이 있고요. 이 두 가지는 이 케이스 페탈리티 레이트는 이 두 가지를 합한 슬라이드인데 굉장히 좀 복잡합니다만 자세한 시간상 자세히 말씀드리지는 않겠습니다. 역시 이 발생한 케이스 대비 사망률이어서 얼마 정도 효과적으로 이 방역을 했는지를 알 수 있는데 역시 그 핑크색의 영국, 그린색의 미국은 상당히 높은 수치들을 보여주고 홍콩은 아까 말씀드린 그 시점이 높지만 중간중간에는 워낙 발생률이 적기 때문에 일단 확진되면 거의 사망하는 케이스만 있었기 때문에 이게 높게 나타나는 그런 수치들을 알 수 있습니다. 싱가포르와 일본은 전반적으로 잘 관리를 한 것처럼 보입니다. 이 6개국과 비교해서는요. 이 슬라이드는 정책이 얼마나 엄격했는지에 대한 겁니다. 그래서 간단히 여기 써 있는 것처럼 9가지 서로 다른 정책의 인디케이터들을 합해서 그래프로 그리는 것입니다. 예를 들어서 학교를 닫았다든지 일을 막 못하게 했다든지 그다음에 이동을 막았든지 앞에 여러 발제자들이 얘기했던 소셜 아이솔레이션의 강도라고 할 수도 있겠죠. 그것들을 갖고 봤을 때 역시 각 나라들이 서로 다른 패턴들을 보여주고 이것들이 그 시간이 지남에 따라서 또 방역 수위들을 바꾼 것들을 알 수 있습니다. 예를 들어 미국 같은 경우에는 초반에 굉장히 강력하게 시작을 했죠. 왜냐하면 사람이 많았기 때문에. 그러다가 백신의 여부에 따라서 굉장히 높고 낮음의 차이를 두는 이 파란색 것의 에버리지입니다. 그런 차이들을 보실 수 있고요. 일본은 지금까지도 상당히 전반적으로 높은 방역 수치를 유지하고 있습니다. 싱가포르는 앞에 수치들이 두 나라 다 잘 이 6개 헬스 앤 케어 시스템 중에는 잘 방역한 거지만 싱가포르는 보시면은 일본보다는 훨씬 좀 더 그 수위를 낮춰서 조절을 한 것을 볼 수 있습니다. 한국 같은 경우는 초반에 높았지만 우리도 점점 낮추고 지금 가장 낮은 국가 중에 하나로 들어가 있습니다. 그래서 이런 서로 다른 그 코비드의 영향, 그러니까 발생과 사망, 그다음에 이거에 대한 정책의 수위가 다른 것들이 물론 이 자료들이 각 나라마다 이걸 보고하는 방식이나 자료를 보고하는 방식들이 조금씩 차이가 있고 완벽하게 데이터를 모으지는 못했을 겁니다. 여러 차이들이 있기 때문에 그래서 우리가 그것 아주 자료의 신빙성에 있으면 조금 이제 주의를 해서 봐야겠지만 이것 자체가 앞에 각각의 5개 그 시스템에 대한 소개와 그 경험을 각각을 볼 때를 이렇게 전체 오버뷰를 갖고 볼 때는 이 정보들 자체가 또 새롭게 우리가 논의할 이 토론의 이제 뷰를 보여줍니다. 그래서 코비드 어택의 패턴도 각 나라가 달랐죠. 언제 온셋을 했고 얼마나 자주 웨이브가 왔는지 어떻게 정도의 영향이 있는지도 달랐고요. 그 다음에 정책의 엄밀성, 스트링전시들도 보시면 서로 다릅니다. 그래서 어떻게 코비드를 이제 컨트롤하려고 하는지의 그 수위들이 이거에 따라 또 다른 것을 알 수 있습니다. 굉장히 강력하게 한 국가, 처음에 강력하게 낮춘 여전히 또 그 내에서 백신 여부에 따라 차이를 둔다든지 이런 차이들을 볼 수 있습니다. 이건 굉장히 여러 가지 이유에서 기인할 겁니다. 그래서 앞에 발제자들이 얘기하셨던 노인들의 경험, 노인들이 거기서 그 정책에 반응한 것들, 이 모든 것들은 사실 이런 어떤 큰 그림 안에서 사실 이루어진 일들인 거죠. 그래서 그 원인들에 대한 그 인과에 대한 것들을 정확히 알지 못해도 이것들이 어떤 식으로 이루어졌는지에 대한 좀 더 많은 연구가 좀 필요하다고 생각합니다. 단지 이 리진은 단지 의료적인 부분만은 아닐 겁니다. 이 코비드가 보건적인 문제지만 감염병이지만 그 외에도 사회, 문화 또 어떤 제도적인 팩터들이 이런 정부의 정책의 결정에 많이 미쳤겠죠. 그리고 이것들은 또 그 노인들의 삶과 건강에 영향을 미치는 방식이었을 겁니다. 이것들이 어떤 식의 기전이었던지 그리고 그 각각의 시점에서는 어떤 영향이 있는지에 대해서 우리가 좀 더 많이 알 필요가 있습니다. 지금은 그 각 시점, 피리어드마다 나라 그 경험이나 이런 게 바뀌었을 텐데 특히 이제 노인 관련된 게 지금 보여드린 것도 전 연령층에 대한 정보들만 저렇게 가능합니다. 그래서 그것들의 임팩트를 우리는 굉장히 어렴풋이만 알 수 있지만 사실은 그 안에 여러 스토리들이 있을 것 같습니다. 그래서 그것들에 대한 우리가 좀 더 많은 이해가 있어야 하겠습니다. 그리고 또 하나 여기서 말씀드리고 싶은 건 지금 앞에 보여드린 저런 슬라이드들이 굉장히 복잡한 이 코비드 현상을 그래도 특히 이렇게 국제간 비교하는 연구들을 또 발표들을 통해서 이해하는 데 굉장히 큰 도움이 되는데 아쉽게도 연령 특이적 혹은 뭐 성별 특이적인 자료는 제공하지 않습니다. 제가 그 다른 그 국제 비교 연구를 작년 걸쳐서 할 때 이제 그때 몇 개 국가들 이런 식으로 비교하는 연구였는데 저는 이제 노년학자다 보니까 노인 관련 자료를 찾으려고 했는데 정말 찾기가 어렵습니다. 각 나라에서 이제 어떻게 갖고 있겠지만 이거를 이렇게 모아서 한다는 건 굉장히 어렵더라고요. 만약 노인들한테도 저런 식의 자료들을 우리가 구축할 수 있었다면 훨씬 더 생생하게 노인들의 받은 영향들 또 정책의 효과들과 노인의 건강 삶의 영향을 알 수 있을 텐데 그런 것들이 좀 아쉽습니다. 그래서 우리는 그 제안하는 것은 좀 더 많은 좀 좋은 그 노년 특이적인 어떤 비교 자료들을 좀 모으면 좋겠고 그런 것들이 이제 각 국가의 경험들을 더 배우고 나누는 데 훨씬 큰 도움이 될 거라고 생각합니다. 두 번째는 두 번째 포인트는 거의 모든 슬라이드에서 공통적으로 나왔던 어떤 그 배움 우리가 알고 있는 이제 결과에 대한 좀 흥미로운 점이 있어서 그에 대해서 토론을 하고자 합니다. 그 진실은 뭐냐면 한번 어쨌든 그 감염되면 노인은 굉장히 사망할 확률이 높은 것 같습니다. 거의 모든 국가 연구자들이 얘기했고요. 하이 케이스 피탈리티 레이트를 올더 포퓰레이션은 알 수 있고요. 근데 우리가 혹은 일반인들이 노인에 대해서 알고 있는 혹은 잘못된 그 상식, 잘못된 것도 있는 것 같습니다. 예를 들면 노인은 항상 가장 많이 감염되는 그룹이라고 생각을 하십니다. 그렇지만 오늘 발표들을 보시면은 어떤 그 보건 시스템, 그 어떤 나라에서는 노인들이 덜 감염되기도 했다고 보고를 합니다. 일본, 한국도 사실 마찬가지입니다. 자료를 보시면. 그 이유가 사실 어떤 면에서는 당연하죠. 노인들은 매일매일 직장을 갈 필요도 없고 매스 게더링을 하지도 않고 원래 좀 아이솔레이션 돼 있었기 때문에 상당히 좀 잘 피할 수 있죠. 그래서 노인들은 감염률 자체는 그렇게 높지가 않은 게 팩트입니다. 사실인 거죠. 두 번째는 모든 노인들은 다 허약하고 코비드 동안 멘탈리 챌린지 될 거다. 되게 힘들었다. 이게 노인들에 대한 생각입니다. 그렇지만 오늘 발표에서 보시면 일본 노인들은 그렇지 않습니다. falsely believe와 달리 상당히 resilient-합니다. 이거는 아마 제가 작년 봄에 노년학회에서 발표했던 이제 포스터에 같은 결과가 한국자료를 갖고도 이제 나왔는데요. 보면 이제 여러 논문들과 이제 다른 나라 연구들 그때 당시 이렇게 리뷰하면서 봤을 때 흥미로운 점은 노인들은 시간과 또 삶의 어떤 어려움이 닥칠 때 그거에 대한 인식이 젊은 사람과 상당히 다르다는 겁니다. 이것만 이제 not only explanation 아니죠 물론 그렇지만 상당히 그게 흥미롭게 뭐냐면 노인들은 이제 생의 마지막에 가까워 있기 때문에 그 한순간 한순간 굉장히 소중하게 생각한다는 점 그리고 어떤 어려움이 와도 이미 긴 세월을 사는 동안 여러 어려움들을 많이 겪었기 때문에 이게 또 한 번 이 또한 지나가리라 이런 좀 관조적인 생각들 갖고 있다는 겁니다. 그래서 less destructive, more positive한 그런 노인들이 상당히 있다는 겁니다. 강한 노인들이 있는 거죠. 예. 그런 노인들이 있다는 것들을 오늘의 그 발표에서도 알 수 있었습니다. 세 번째 잘못된 그 믿음은 노인들은 항상 케어를 받는 사람이다라는 겁니다. 그렇지만 오늘 우리가 발표를 통해서 알듯이 그렇지 않습니다. 일부 케이스들에서는 노인들은 오히려 케어를 단지 받을 뿐만 아니라 어떤 지역사회에서 다양한 볼런티어링 활동 같은 걸 통해서 더 넓은 지역사회 주민들을 지역사회를 위해서 봉사했습니다. 그리고 이거는 노인들이 돌본다고 할 때 그건 아마 자기 남편이나 부인, 자기 어머니일 거야 라고 생각을 하지만 그렇지 않습니다. 오늘의 사례를 봤을 때 여러 볼런티어링에 노인분들이 참여를 하십니다. 건강한 노인들이요. 제가 지난 3년 코비드 동안 어쩌다 보니 지역사회에서 서울의 좀 낮은 저소득층 지역사회에서 사업들을 했을 때 많은 건강 주민 리더들이 저희 건강 리더라고 부르는 주민들과 사업을 했는데 상당수의 분들이 60 플러스 이상이셨습니다. 많은 노인들을 돌보셨고 주변에 그 지역사회를 위해서 봉사하셨습니다. 그래서 노인들은 항상 뭔가 받는 사람이라는 그 케어를 받는 사람이라는 것은 잘못된 그 믿음인 거죠. 그래서 이런 발표의 포인트들을 들을 때 코비드 동안 노인에 대한 이미지에 대해서 우리는 어떤 것이 이루어졌나를 한번 생각해 볼 필요가 있다고 생각합니다. 어쩌면 노인은 여러 미디어를 통해서 굉장히 허약하고 사회에 굉장히 부담이 되는 그런 그룹, 이렇게 혹시 이미지화되지 않았나. 그리고 이거는 어떤 면에서는 또 다른 스테레오타이핑이 아닌가 생각합니다. 우리가 모두 싸우려고 fight against 하고 싶은 에이지즘의 또 다른 양상이 아닐까 그런 생각을 해봅니다. 만약 그렇다면 우리 무엇을 어떻게 해야 될까요? 이런 말씀을 한번 나눠보고 싶었습니다. 그다음에 이제 세 번째 포인트는 이거 역시 그 많은 그 발표에서 공통된 점인데 앞에 슬라이드에서 제가 토론 두 번째 포인트 말씀드렸던 것처럼 모든 노인이 다 허약하고 짐이 되는 건 아닙니다. 말씀하신 대로 건강한 노인들 그리고 사회경제적으로 어느 정도 위치가 있는 자기가 잘 프로텍션 하는 노인들은 상당히 긍정적인 또 방식으로 코로나를 대응했습니다. 하지만 여전히 노인 중에 상당 부분의 노인들은 코비드로 인한 영향을 많이 받았습니다. 중요한 거는 그 임팩이 unequal하다는 겁니다. 그래서 모든 노인이 동일하지 않다는 거, 어떤 특별한 그룹에 더 영향이 컸다라는 겁니다. 그래서 특히 프레일한 올더 피플이겠죠. 피지컬 프레일티도 있고 소셜 프레일티도 있겠습니다. 이코노믹 프레일티도 있죠. 그리고 이 그룹은 대부분 장기요양 니즈를 가진 분들입니다. 그리고 거의 모든 나라들에서 차이들은 있지만 35% around 한 그 정도 수치가 사망자의 한 30에서 40% 정도가 널싱홈에 있는 시설화돼 있던 노인입니다. 거기서 서비스를 받았던 분들이죠. 그리고 이게 더욱더 좀 장기요양 생각하는 국가들에게 시사점을 주는 거는 미국과 영국 오랫동안 장기요양을 공식 서비스로 가족 돌봄을 넘어서 제도화했던 이 나라들에서 앞에 보여주셨던 것처럼 훨씬 사망이 높고 그 감염률이 높았던 겁니다. 그래서 우리는 어떻게 이제 코비드 시대에 초고령화 시대에 장기요양 그 프레일한 엘더리를 어떻게 케어할 것인가 이거에 대한 고민을 해봐야 되는 것이죠. 그리고 또 하나 말씀드리고 싶은 거는 여러 발표를 들으면서 이것을 위해서는 반드시 정책적인 개입이 필요하다는 겁니다. Health and Care System Matters입니다. 그래서 유니버설 헬스 커버리지가 있었던 보편보장이 있었던 나라에서는 한국과 뭐 다른 몇몇 나라들은 프리 테스트를 받고 almost free 테스트 트리트먼트를 받았죠. 돈 때문에 걱정할 일은 없었죠. 하지만 모든 나라가 그런 건 아니었습니다. 트리트먼트와 테스트가 엄청난 경제적 부담으로 다가왔고 보험을 갖고 있어도 거기서 그게 거부된다든지 이런 문제가 있었기 때문에 이 부분은 각 개인이 노력한다고 될 수 있는 부분이 아니라 어떻게든 정책을 바꿔야 되는 노력이 필요합니다. 그리고 그걸 어떻게 우리가 만약 없던 나라라면 어떻게 할 수 있는지 있다면 어떤 커버리지가 있다고 해도 그게 여전히 그 힘든 어떤 그룹이 차별받지 않도록 하는 노력이 필요하고요. 프로그램 vs policy 이제 오늘 발표에 많은 것들이 프로그램을 소개했습니다. 지역사회에서 적극적으로 참여하는 분들이 굉장히 필요하죠. 거의 모세혈관 같은 거라고 보시면 됩니다. 그게 있어야 사실은 각 동네 골목마다 서비스가 가는 거죠. 하지만 그것들과 함께 큰 거시비 정책이 없으면 이 두 가지가 서로 발을 잘 맞추지 않으면 어느 한쪽만으로는 성공적인 코비드 시기에 이제 노인의 삶과 건강을 유지하거나 향상하거나 나빠지지 않도록 할 수 없다는 점, 그것들을 연구자들이 다시 한번 생각을 할 수 있게 해주었습니다. 그리고 또 하나 좀 중요한 점들은 아까 또 짚을 만한 점들은 코비드도 문제지만 그렇지만 서브옵티멀 딜리버리 non COVID-19 케어라는 거죠. 그러니까 만성질환 갖고 있거나 신체 심리 장애 좀 ADL 어려운 이런 분들은 사실 코비드는 어떻게 피했는데 코비드 아닌 늘 갖고 있던 만성질환 관리가 안 되는 거죠. 네거티브 임팩 이제 락다운 오래 한다든지 사회적 격리를 계속하고 병원에 가면 뭐 치료받을 수 없고 테스트를 하고 오라는 등 이런 여러 가지 것 때문에 굉장히 어려움을 갖고 온 이분이 사실은 굉장히 큰 그 영향이 장기적으로도 있을 것 같습니다. 그것들에 대한 좀 연구가 장기적으로 필요하고요. 그리고 또 다른 것들은 적극적인, 명확히 코비드와 관련되거나 의료적이지 않더라도 코비드 동안은 앞에 발표 중에 나온 것처럼 노인들이, 좀 젊은 노인들이 일자리를 잃거나 경제가 이제 다운되는 것들, 또 오늘 많이 나누지는 못했지만 사실 그 한국은 아직 이 영향이 없지만 이제 싱가포르이든 다른 나라들 같은 경우는 일본도 그렇고 마이그랜트 워커들 이슈가 굉장히 중요합니다. 그래서 이런 부분들이 코비드 자체 혹은 코비드와 연결되어 있는 조금 더 멀어 보이는 것들이 어떻게 영향을 주지 않는 부분이 이제 중요하고요. 마지막입니다. 그 전문가들이 알고 싶지 않은 뉴스지만 앞으로 5년 안에 또 다른 코비드 같은 팬데믹이 올 거라고 얘기한다고 합니다. 그러면 지금 우리가 논의했던 발표 들었던 이런 것들을 통해서 이번 코비드를 통해서 배웠던 것들을 어떻게 좀 더 잘 대응하기 위해서 또 다른 감염병에 의해서 우리가 준비할 수 있을 것인가 이런 걸 생각해 봐야 될 거고 이게 좀 다차원적인 부분일 것 같아요. 그러니까 테리가 발표했던 소셜 카피탈 빌딩 같은 것도 굉장히 중요한 부분이고 한국에서 더 잘할 수 있는 저희가 한국에서 호스트하니까 그런 부분을 생각합니다. 싱가포르 같은 경우는 이제 디지털 유지를 굉장히 와이드하게 하려고 노력했던 것 같아서 좀 더 잘 어떻게 이걸 활용할 수 있을지 그리고 이게 여전히 격차를 늘리는 건 아닐지 그리고 리터러시를 어떻게 더 올릴 수 있을지 노인들이 실제 잘 사용할 수 있는 노인은 제가 알기로는 10명 중에 3명 이제 한국 경우에 연구들을 해봤을 때 그랬기 때문에 이 부분이 모두가 더 차별하지 않도록 하는 그 방향으로 가야 되는 거 그리고 이런 것들을 이제 오늘 같은 이제 서로 다른 국가 간에 이제 배우고 또 협력함으로써 좀 더 잘 준비할 수 있지 않을까 또 다른 이런 협력도 나누는 기회를 기대해 봅니다. 네, 이상입니다. 감사합니다.
네, 김홍수 교수님 좋은 토론 정말 감사드립니다. 예, 굉장히 인사이트풀했던 것 같고요. 이따가 또 종합 토론 시간에 발연자분들께서 들어오시니까 그때 또 저희 같이 한번 이야기 나눠봤으면 좋겠습니다. 그럼 잠시 기다려 주시고요. 감사합니다.
감사합니다.
네. Okay, well, thank you so much for the insightful discussion from Professor Hong-Soo Kim. So she made, in general, 3 points. So first, she mentioned some variations in the data across 6 different countries, including, of course, Korea. So it was really helpful to compare some notes. So it was very helpful. The 6 countries include the US, UK, Singapore, Hong Kong, Japan, and Korea. And also she mentioned 2 parts in terms of shared findings across the 5 presentations. So she mentioned some, fact, actually, the true fact, and also some false information that we actually misconceived. And also she mentioned some implications like another pandemic like COVID-19 would come within couple of years. So how can we prepare for that sort of thing? So she actually made some insightful questions out of these shared findings from the most presentations. So it was very helpful, and we can continue discussing these parts in the overall discussion and question and answer session later on. 자, 그러면 이제 다음 주제 토론으로 넘어가 보도록 하겠습니다. So our second discussant is Professor Yong-ho John. So Dr. John is an associate professor in the Department of Social Welfare at Incheon National University in South Korea. 저희 이번 두 번째 토론은 전용호 교수님이 해주시겠는데요. 전용호 교수님은 인천대학교 사회복지학과 부교수이십니다. Okay, so let us welcome our second discussant, Professor Yong-ho John. 자, 그러면 이번에 두 번째 발제자이신 전용호 교수님을 모시겠습니다. 힘껏 환영해 주십시오.
네, 반갑습니다. 소개받은 인천대학교 전용호입니다. 네, 대표 자료를 좀 띄워주시면 감사하겠습니다. 네, 저는 이 시간에 그 5 외국의 사례들을 바탕으로 좀 한국의 상황들과 경험들, 그리고 우린 되게 스트릭트한 그 록다운의 리스트릭션을 통해서 특히 이제 노인들의 이 요양원이나 지역사회에서 되게 강력한 규제를 록다운을 해서 폐쇄 조치를 했었는데, 이제 그러한 것들로 인한 여러 가지 결과와 영향성들, 이런 것들을 살펴보고 이 코비드 19이 우리 사회의 전반적인 어떤 구조나 사회 문제들을 더 심각화시키는 건 아닌지, 그런 관점에서 몇 가지 사항들을 말씀드리겠습니다. 그래서 처음에 있는 것처럼 우리가 이제 코비드 19이라는 그러한 전염성이 강하고 되게 이제 특히 노인들에게 사망률이 높은 이러한 상황에서는 이 폐쇄가 상당히 이제 불가피한 측면들이 여러 가지가 있죠. 그래서 이 아시아 국가들은 very strong한 그런 스트릭트 록다운의 정책들을 많이 펼쳤습니다. 일정 부분은 불가피한 측면이 있지만 이게 장기화되면서 상당히 여러 가지 문제들이 심화되는 측면들이 있는 것 같습니다. 그래서 여러 가지의 심각한 사회적 프로블럼을 많이 나오고 있고, 그래서 우리가 이제 이러한 것들의 경험을 바탕으로 이 록다운이라는 것은 매우 쉽게 할 수 있는 정책이지만 그로 인해서 초래되는 여러 가지 문제점들이 매우 심각하고 중요하기 때문에 여기에 쓰는 것처럼 우리가 좀 더 이노베이티브하고 그러한 대안들, 얼터너티브스를 좀 찾으려고 노력한다는 것들이 많이 필요한 것 같습니다. 예를 들면은 잘 아시는 것처럼 우리가 코로나 기간 동안에 재가 서비스나 노인들 같은 경우 정말 돌봄 서비스가 있어야만 생활에 영유를 할 수 있는 노인들이나 이런 분들이 방문 요양 서비스나 주간 보호 서비스, 이러한 것들을 상당히 이제 셧다운 시켰고, 특히 이제 요양원에 계시는 어르신들, 요양병원의 어르신들은 엄격하게 통제하면서 밖으로 나가지 못하게 하는 그런 정책들을 펼쳤습니다. 그것들이 상당히 수년간 장기간 동안 이루어졌고, 이제 그러한 것들이 말씀드린 것처럼 감염을 최소화하기 위한 불가피한 정책이긴 하지만 여러 가지 면에서 이제 문제가 발생을 하죠. 아까 여러 발표에서 주신 것처럼 영국이나 일본이나 다른 나라의 여러 발표에서도 나오는 것처럼 신체적 기능의 저하와 이런 것들이 되게 많습니다. 특히 저는 이제 구체적인 그러한 지표로나 결과로 나올 수 있는 정신건강 영역에 있어서 노인뿐만이 아니라 많은 사람들이 매우 심각한 상황이고, 적극적인 지원이 이루어지지 않으면 상당히 이 문제가 각종 사회 문제를 심화시킬 수 있는 기제로서 작용할 것인지에 대한 우려가 많이 있습니다. 영국의 발표와 비슷하게 노인들이 더 리스트 임팩티드 그룹이잖아요. 그러니까 상대적으로 코로나로 인해서 많이 돌아가셨지만 우울이나 정신이나 이런 면에 있어서 좀 상대적으로 영향을 적게 받은 그룹이긴 합니다. 그렇지만 전반적으로 노인들의 그러한 우울감이나 suicide thinking, 그러니까 자살 생각률 같은 경우를 보면은 올해 상반기의 데이터를 보면은 여전히 코로나가 발생하기 이전인 2019년에 비해서 2배나 4배 정도 높은 상황이라고 볼 수가 있습니다. 잘 아시는 것처럼 한국 같은 경우에는 워낙에 높은 자살률, 세계 최고의 자살률, OECD 최고의 자살률을 보이고 있는 그러한 오명의 국가인데, 이런 상황에서 우리가 이러한 이슈들을 그대로 놔두면은 안 되고 적극적인 개입이 정말 시급한 상황이다라고 볼 수 있습니다. 그래서 이제 이게 2022년에 보건복지부의 정신건강 실태 조사에 보시면 결과이면 아시겠지만 사실 아까도 말씀드린 것처럼 노인들은 2022년 6월의 기준으로 보면은 우울 위험군이 13% 정도 됩니다. 근데 상당히 이제 이게 취약한 게 이제 30대 분들인데 24.2%가 우울의 위험군에 속하고 계시고요. 그렇죠? 성별로 보시면 남성과 여성, 특히 여성분들의 우울이 되게 높은 수준입니다. 물론 이제 코로나가 엔데믹으로 가면서 그러한 지표들이 좀 더 개선되는 측면들은 있지만 여전히 코로나가 발생하기 이전보다는 5배가 넘는 수지로 위험한 수준이죠. 그래서 우리가 이제 이렇게 전체 국민, 노인을 포함해서 전체 국민의 정신건강 상태가 매우 취약하고 어려운 상황이 있기 때문에 이제 이러한 상황들에 대해서 좀 더 심각한 문제의식을 가지고 대응을 하는 것이 필요하다라고 볼 수 있을 것 같습니다. 우울뿐만 아니라 자살 생각률, suicide thinking rate라는 측면에 있어서도 평균치가 12.7%인데 2019년에는 4.6%입니다. 거의 이제 3배 정도 되는 높은 상황이고요. 그래서 아까도 말씀드린 것처럼 노인들은 그래도 7.3%로 낮죠. 그렇지만 뭐 2020년 5월의 지표를 같은 경우 보면은 suicide thinking rate가 4.7 정도 됐고, 그렇죠. 그래서 평균에 비하면은 여전히 높은 상황이고 노인들은 낮지만 상당히 이제 우리 30대와 이러한 40대 중장년들도 상당히 정신 건강의 상태가 좋지 않고 자살을 생각하고 있는 상황입니다. 성별로 보더라도 아까 우울에서는 여성분이 많았지만 여기에서 보면 이제 남성들의 우울도 상당히 높은 상황으로 더 높은 상황으로 나오고 있습니다. 그래서 이렇게 우울과 자살 생각률이라는 하나의 이 두 가지의 지표로만 보더라도 코로나가 장기화되면서 국민들의 정신 건강 상태가 매우 유중한 상태이고 상대적으로 노인 집단들은 다른 집단들에 비해서는 양호한 상태이지만 코로나 이전과 비교하면 여전히 노인들도 이런 자살 생각과 우울에 있어서 심각한 영향을 받고 있는 상황이다라고 볼 수가 있을 것 같습니다. 그래서 이제 제가 우려하는 것은 바로 이겁니다. 우리 사회에서 이 많은 사람들이 사실은 외롭다고 이야기를 하죠. 그렇죠? 어르신들도 많이 특히 외롭습니다. 그렇죠? 잘 아시는 것처럼 이 어르신들의 외로움은 경제적, 사회적 어떤 역할과 활동 측면에 있어서 감소 이런 면에서 역할이 될 수 있겠죠. 그렇죠? 근데 이제 문제는 이 외로움이라는 것이 상당히 만연해 있어서 이 외로움이 여기에 나와 있는 것처럼 개인적인 측면의 어떤 인디비주얼한 필링이 아니라 어떤 감정적으로 누가 없거나 사람이 없어서라고 하는 그런 개인적인 감정의 차원으로서 생각할 것이 아니라 제가 보기에는 우리 사회가 급격하게 변화를 겪고 있고 그러한 변화의 과정과 그러한 결과로서 많은 사람들이 더 외로움을 느끼는 것이 아닌가라는 생각을 갖고 있습니다. 좀 더 이런 것들은 엠피리컬한 실증적인 데이터를 가지고 분석을 해야 되는데 여러 가지의 상황들을 보면은 이런 것의 이런 구조적인 사회 변화의 과정과 그러한 결과로서 많은 사람들이 외로움을 겪고 있고 특히 노인들이 이러한 외로움이 매우 취약한 그러한 집단으로 보이고 있습니다. 좀 더 구체적으로 말씀을 드리면 여기에 나와 있는 것처럼 드라마틱한 change of institutionalized individualism이다. 이게 무슨 얘기냐면은 우리 사회가 코로나 이전에부터 상당히 제도화된 인디비주얼리즘의 경향으로 가 있다. 그러니까 전통적으로 가족이나 지역사회나 이러한 가부장적인 어떤 가족 구조나 사회 분위기 속에서 대개 개인들이 숨쉴 공간이 없었고 집단적인 그러한 경향성들이 강한 사회에서 우리가 압축적인 근대화와 그런 것들을 통한 경제 발전의 과정 속에서 이제 상당히 서구처럼 그러한 제도화된 개인주의화의 길로 걸어가고 있는 것으로 보입니다. 이제 이 제도화된 institutionalized individual이라는 개념을 이제 울리백, 이 사회학자 울리백이 하는 개념인데, 우리도 이제 그러한 경제 수준과 여러 가지 사회 여건과 개인주의화 이런 걸로 인해서 개인주의화가 제도화되고 있다. 이제 이러한 것들에 대해서 이제 서울대학교의 장경섭 교수님 같은 경우는 상황적 개인화라는 이런 얘기를 하더라고요. 상황적 개인주의화. 그래서 우리나라는 대개 압축적 근대화와 압축적인 사회 변화의 과정 속에서 이런 여러 가지 상황으로 인해서 개인화가 촉진되는 측면들이 있었는데, 그런 식의 개념을 통해서 설명을 하기도 합니다. 진단은 좀 다르지만 어쨌든 간에 우리나라가 큰 틀에 있어서 서구처럼 되게 개인화, 개별화적인 과정으로 겪고 있다라는 것이고, 그걸 볼 수 있습니다. 두 번째는 decreasing relationship and caring role of family and community에 있는 것처럼 가족이라는 것의 역할과 기능이 많이 변화되고 있다는 거 잘 아실 것입니다. 특히 한국의 저출산 고령사회라는 측면에서 보면은 가족이 여러 가지 면에서 과부하된 상태이고, 국가가 수행해야 될 여러 가지 역할들을 가족이 수행하면서 그게 과중화되면서 이제 젊은 세대 같은 경우는 아예 왜 결혼이라는 거를 안 하고 그냥 자유로운 삶을 선택한 이런 것처럼 기존의 가족이 수행하던 여러 가지 역할들, 특히 이제 이러한 것들이 전통적으로 노인 같은 경우에는 이미 이제 자녀의 부양을 기대할 수 없는 상황으로 가는 게 있잖아요. 그래서 여러 가지 이러한 가족의 돌봄 역할이나 관계 형성에 있어서 상당히 변화가 나타나고 있고, 그게 이제 가족뿐만 아니라 지역사회 차원에서도 잘 아시는 것처럼 요즘에는 그래도 공동체, 커뮤니티가 루럴에리아는 있었다라고 하지만 이제 농촌 지역에서도 더 이상 이러한 공동체가 사라져간다 이런 얘기를 많이 하고 있거든요. 도시 지역은 이미 그러한 것들이 없어져 가고 있는 상황에서 농어촌 지역도 그러한 관계성이 축소되어 가는 공동체가 약화되는 상황에 있기 때문에 상당히 이러한 여러 가지의 변화들이 사람들의 삶에, 개인들의 삶에 영향을 미치고 있다라고 볼 수가 있습니다. 특히 잘 아시는 것처럼 우리나라 같은 경우, 사우스코리아 한국 같은 경우는 이러한 노인 빈곤율이 여전히 45%로 상대적 빈곤율이 높은 상황이고, 이 코로나 시기에 정말 필요했던 보건의료와 복지, 그러한 여러 가지 재가와 지역사회에 기반한 서비스 체계들이 상당히 이네디커죠, 부족하죠. 그러다 보니까 어르신들이 사람들과의 교류나 이런 것들을 할 수 없고, 적절한 위기의 상황에서 지원을 받을 수 있는 인프라가 너무나 취약하다는 것입니다. 잘 아시는 것처럼 아까 이제 아까 미국 같은 경우에는 발표해서 홈바운드를 위한, 그러니까 집에 있는 그런 분들을 위한 여러 가지 서비스를 찾아가서 많이 했지만, 우리는 의사의 방문 진료 서비스도 거의 부재하고, 간호사에 의한 방문 간호 서비스도 제도적으로 있지만 여러 가지 이 장애물들에 의해서 활성화가 되어 있지 않은 상황입니다. 그러다 보니까 어른들이 적절한 의료 서비스를 이용하지 못하고 있고, 코로나가 급격하게 확산되면서 방문 요양이나 이러한 서비스들도 많이 중단이 되었고, 지역 단위의 주간보호 서비스 같은 경우도 많이 셧다운이 되어 있었습니다. 그래서 이러한 기존의 보건의료, 복지, 주거, 이러한 사회보장 체계가 튼튼하지 못함으로 인해서 더욱더 어려움이 가중되고 있는 상황이라고 봅니다. 이래서 이제 여러 가지 건강의 측면에서 문제가 있지만 사회복지적인 측면에서 보면은 사람들 간의 사회적 관계망의 구조적인 변화가 나타나고 있다라고 볼 수가 있고, 그러한 것들이 여러 가지 요인들에 의해서 상당히 사회적인 과제로서 등장하고 있고 도전으로서 등장하고 있다라는 것이 제가 판단하는 현재 한국의 상황이다라고 볼 수가 있고, 이제 이것은 아까 다른 여러 프레젠터들이 많이 이야기하신 것처럼 이러한 사회적 관계망의 어려움들을 여기 다른 나라들도 많이 겪고 있지만 한국이 상당히 단기간에 압축된 근대화와 경제 변화를 통해서 이런 것들을 더 하는 것 같습니다. 그래서 저는 되게 걱정이 되는 것이 이러한 우리 사회의 vicious circle of lives of people, 그러니까 악순환의 고리가 사회적 구조적으로 만들어진 것이 아닌가라는 우려를 갖고 있습니다. 아까도 말씀드린 것처럼 사람들이 개별화되고 특히 취약 집단이거나 사회적 자원을 갖고 있지 못하는 노인, 장애인, 정신질환자, 노숙인, 그리고 저소득층의 1인 가구 중장년들 이러한 분들이 많은 경우 사회적 관계망에서 배제되고 관계망이 없어서 말할 사람이 없고 심부름 시킬 사람이 없고 부탁할 사람이 없는 그런 상황 속에서 이런 론리니스를 많이 겪고 그렇죠. 사람을 만나지 않고 활동을 하지 않음으로 인해서 외로움을 겪는 사람들이 상당히 많아지고 있고 아시는 것처럼 영국은 디파트먼트 오브 론리니스라는 것들을 했잖아요. 그런 것처럼 그래서 그렇게 있고 이제 그 중에서 외로움을 겪고 있는 사람들 중에서 일부는 이제 이러한 것들이 디프레션의 상태로 빠지는 거죠. 우울증의 상태로 빠집니다. 보시겠지만 그래서 이제 이러한 외로움과 우울증의 일부가 겪고 우울증을 겪고 있는 사람들의 일부는 적절한 치료나 돌봄과 지원을 받지 못하면 사회적으로 고립이 되죠. 사람들을 만나지 않고 스테이 인도어스 하는 상황이 되는 거죠. 이제 그래서 또 일부가 이들에 대한 적절한 지원이 이루어지지 않으면 그 중에 일부는 또 자살하거나 고독후시 일본어들은 고독사의 상황이 될 수도 있는 것이죠. 그래서 우리 사회의 일부의 취약계층이나 사람들에게 이런 것들이 되는 그런 걱정이 있습니다. 그래서 이러한 상황이 팬데믹 상황이 이러한 우리의 트렌드를 더 스피드업 가속화시키고 있고 이미 이러한 악순환의 구조가 만들어지지 않았는가라는 우려가 있습니다. 그래서 이제 이러한 것들에 대응해서 정말 이 제대로 된 복지국가, 보건의료, 복지, 주거 이런 것들이 만들어지고 좀 더 릴레이션십을 강화시킬 수 있는 웰페어 팔러시가 더 만들어지지 않을까 생각이 듭니다. 그래서 이런 급격하게 변화하는 개인의 그런 변화, 가족의 변화, 지역사회의 변화 이런 것들에 대응해 1인 가구의 급격한 증가에서 올 수 있는 것처럼 이러한 관계의 이슈들에 대해서 적극적으로 대응하지 않으면 이 비셔스 사이클에 나타나는 여러 가지 문제점들이 우리 사회에 더욱더 심화되고 고착화되는 것이 아닐까라는 그러한 우려가 있습니다. 네, 이상입니다. 감사합니다.
네, 전용혁 교수님의 굉장히 재미있고 풍성한 그런 디스커션 정말 감사합니다. 좀 이어서 또 이따가 종합 토론 시간에 진행을 해보도록 하고요. 더 풍성한 디스커션이 이어질 것으로 생각됩니다. 그럼 다음 세 번째 발제로 들어가 보도록 하겠습니다. So thank you so much for Dr. John for your helpful and insightful discussion. It was very helpful, and we can continue discussing in the overall discussion and Q&A session later on. So let's move to the next discussion session. So our third discussant is Dr. Seon Won. So Dr. Won is a legislative researcher at National Assembly Research Service. 자, 세 번째이자 마지막 토론은 원시현 박사님이 해주시겠는데요. 원시현 박사님은 국회 입법조사처 사회문화조사실 입법조사관이십니다. 굉장히 오래 기다려주셨는데요. Okay, so let us welcome our third and the last discussant, Dr. Seon Won. 자, 오래 기다려주신 원시현 입법조사관님을 모시겠습니다.
Hello everyone. It's a long day, isn't it? It's a great honor to be here. Thank you for having me today. I'm Seon Won, PhD in Political Science and a legislative researcher of National Assembly Research Service. 안녕하십니까? 저는 국회 입법조사처의 원시현 조사관입니다. 저는 학회의 관계자로부터 오늘 이 국제 세미나에서 되도록 이제 영어로 좀 토론을 해주셨으면 하는 그런 요청을 받았기 때문에 영어로 우선 토론을 하고 그리고 간략하게 한국말로 요약을 하는 방식으로 진행을 하도록 하겠습니다. I think presenters today might be tired because of the jet lag, so I will try to hurry up. The title is Vulnerability of Older Adults in South Korea. Yes, let's go to the content page. As you can see, my presentation contains various content such as suicide rate by age, older adult income poverty rate, and labor participation rate by age, and perceived health status by age, and impact of COVID-19 on older adults, and concluding remarks. South Korea is not only dynamic, but also very unique society. While it has the world's best IT technology and medical standards, it has the world's highest level of poverty and suicide among the elderly. We have experienced outstanding economic growth. Still, the welfare system falls far short of that. There's also a wide gap between advanced institutional responses and reality. That's why pride and dissatisfaction exist at the same time. I hope today's presentations and discussions will be helpful to reduce the gap in the near future. According to the chart, Korea is the #1 country with the highest suicide rate. If you look more closely at them by age, you will see the older people's suicide rates are generally higher than overall in every country, but suicide rates rise dramatically with age in Korea. Moreover, they are significantly higher than those of other countries. And let's go to the next page. Surprisingly, Korea also ranked first in terms of older adult income poverty rate. The income poverty rate of the elderly is also significantly higher than that of other countries. And you can see how high it is compared to the average. In addition, the old group is more vulnerable than young old group, and we can see the gender gap too. And older adult income poverty leads to high labor participation, as you can see. When you compare it to the average, you realize how big the difference is. Although they are old, they have to work to earn living expenses. So the health condition perceived by the elderly in Korea is not that good. Of course, there may be a difference between the perceived health condition and the actual one. Nevertheless, we know that perceived status is very important. So far, we have looked at the reality of older adults in Korea. Then let's take a look at the impact of COVID-19 now. According to the COVID-19 death toll and death rate by age during last 2 years, you can see how vulnerable the elderly is regarding death issue. And to make matters worse, Korea will enter the super-aged society in 3 years. What should we prepare? Unfortunately, we are still in a state of unpreparedness. especially, for example, the cremation facilities. On March this year, COVID-19 brought unprecedented cremation crisis in Korea. Funeral procedures could not be performed in time due to a lack of cremation facilities. South Korea is expected to enter a super-aged society. As I told you, what should we prepare? Access to the dead bodies or dying people. Absolute majority of them were older adults, was strongly banned in accordance with infectious disease regulations. At the end of life, every COVID-19 confirmed and dying elderly should be completely isolated from anyone who otherwise would have kept the elderly's deathbed. And due to infectious disease control, almost all the offline activities, especially voluntary meetings and community leisure programs for older adults, have been delayed and cancelled. Senior welfare community centers for healthy older adults and daycare facilities for long-term care were closed. Home care services were provided very limitedly, and families' care burden has been increased. One-person households has no choice but to stay watching TV all day long for months. Many thanks K-trot singers. And finally, this is concluding remarks. During last 3 years, the National Assembly of the South Korea has struggled to cope with pandemic crisis. Infectious disease, quarantine measures, and even vaccination policy were dealt with as political issues for elections. As a legislative researcher and parliamentary officer, it was a hard time to maintain political neutrality between government party and opposition party. How to overcome the COVID blues as well as the loss of muscle mass due to lack of physical activities matters for older adults. Numerous research tasks will be piled up for the post-pandemic era. I wish many researchers to achieve success in their work. Thank you for attention. 네, 제가 이제 한국어로 간략하게 제가 발표한 내용에 대해서 요약을 하겠습니다. 저는 앞서도 이제 많이 말씀이 나왔는데 한국 노인들의 어떤 취약성에 대해서 발표를 드렸고요. 뭐 팬데믹 문제도 있었지만 그 전부터 워낙에 자살률이 높고 그리고 또 빈곤율이 높은 우리 어르신들이 계시고 이분들이 지금 코비드 19 이 시대에 상당히 고통을 많이 겪으셨다. 그리고 실제 그 사망자 수에서 노인분들의 그 사망률이 굉장히 높게 나타났기 때문에 그리고 이분들한테 이렇게 우리가 고립된 이분들에게 뭔가 대책을 시급히 마련해드리지 못했던 그런 문제들이 또 있었던 그런 측면도 있었기 때문에 그런 부분들을 조금 더 부각해서 오늘 발제를 했습니다. 예, 여기까지 발표를 하겠습니다. 감사합니다.
Thank you so much for Dr. Won. It was very insightful and helpful, and I'm sure all the audience would actually learn a lot from your discussion. And she actually shared a lot of the current situation among Korean older adults in Korea. That was very helpful. 좋은 토론 굉장히 감사드리고요. 원시현 박사님 오늘의 또 굉장히 마지막 발표셨는데 늦게까지 이렇게 잘 기다려 주셔서 대단히 감사합니다. 자, 이제 세 분의 모든 발제 토론은 마쳤고요. 이제 마지막 순서인 맨 마지막 overall discussion 세션이 이제 남았습니다. Okay, so now we learned from all three discussants from Korea, and all three discussants made important points regarding the cases in Korea during the COVID-19. So in this, so we are now turned to the overall discussion and question and answer session. So in the overall discussion and question and answer session, speakers and expert panelists will discuss together various issues related to the new opportunities and challenges for our older adults in the post-pandemic era. Also, we will have an opportunity to ask questions to our speakers from the 5 different countries. 자, 종합 토론과 Q&A 세션에서는 해외에 계신 이 지금 들어와 계신데요. 모든 연자분들과 또 아까 김홍수 교수님께서도 줌으로 이렇게 토론으로 참여해 주셨고, 그래서 연자분들과 토론자분들을 모시고 포스트 팬데믹 시대를 살아가는 노인의 삶에 대한 새로운 기회와 도전과 관련된 그런 이슈를 함께 한 자리에 모여서 이야기해 보도록 하겠습니다. First, I'd like to thank all the presenters from the US, UK, Singapore, Hong Kong, and Japan, and also discussants from Germany, and also right here. So you can see all the participants for the symposium. It's just wonderful to see everyone, and also joining us online and participating here physically. So it was probably not possible to have this wonderful symposium without you, and without your expert knowledge and all that. So we deeply appreciate your hard work and effort. So I thank you first. 자, 우선 토론에 참여해 주신 여러 연자분들과 또 우리 그 토론자 선생님들 여기 직접 현장에 참여해 주시는 분, 또 여기 지금 온라인으로 참여해 주신 김홍수 교수님 지금 독일에 계시다고 전해 들었는데요. 그래서 너무 감사드리고요. 사실 지금 이곳에 계신 이 모든 분들이 계시지 않았다면 이렇게 풍성한 심포지엄을 만드는 것이 불가능했을 것 같습니다. 그래서 다시 한번 굉장히 열심히 이렇게 공유해 주시고 토론 이어주시고 그러신 연자분들과 토론자분들의 노고에 진심으로 감사드립니다. So in this overall discussion and questions and answer session, we have a total of 8 experts from all of the world. So we have 5 speakers, as you already know from their presentations. Dr. Grant Phillips from USA. Hello, Dr. Phillips. And Dr. Martin Hyde from UK. Hi, Dr. Hyde. And Dr. Terry Long from Hong Kong. Hello. And Dr. Angelique Chan from Singapore. Hello, Dr. Chan. And Dr. Huang Chue from Japan. Hello, Dr. Chue. So Dr. Huang Chue is actually co-authored with Dr. Yasuyuki Gondo, and joining us this discussion session on behalf of Dr. Gondo. And we very much appreciate Dr. Chue for your participation. We very much appreciate it. 자, 이 종합 토론과 Q&A 세션에는 총 8분이 참여하시는데요. 먼저 5분의 연자분들을 제가 소개드렸고요. 연자분들은 지금 화면에서 보시는 것처럼 또 프레젠테이션에서 보셨던 것처럼 닥터 코란 필립스 박사님, 미국에서 오신 연자분, 그 다음에 마틴 하이드 교수님, 영국에서 오신 교수님이시고, 그 다음에 테리 럼 교수님, 홍콩 연자분이시고, 그 다음에 앤젤릭 찬 교수님, 싱가포르 연사분이시고, 그 다음에 마지막으로 지금 최황 박사님께서 일본 연자분이시었던 야수유키 곤도 교수님을 대신해서 지금 코아서이시기 때문에 이렇게 토론에 참여해 주셨습니다. And we also have 3 discussants, as you can already just see. So Dr. Hong-Soo Kim, she is currently joining us via Zoom. Hello, Dr. Kim.
Yeah.
And as you can see on the right-hand side on the screen, we have also Professor Dr. Yong-ho Jeon, and also Dr. Sian Won. You just saw. 자, 이렇게 토론에 지금 참여해 주시는 세 분 교수님이십니다. 김홍수 교수님, 전용호 교수님, 그다음에 원시연 입법조사관님 이렇게 모시고 함께 토론을 진행해 보도록 하겠습니다. So I think it was very, great discussion and great presentations, I think. And in the meantime, I know, the discussants and also have a lot of questions to the our panel, our presenters. So I would like to actually first, we have actually a lot of questions from the audience. So I'll actually ask each of the participants, and as a presenter, I will actually ask those first, and then we can actually do some overall discussion. How about that? Is that okay? Okay. 자, 우리가 지금 연자분들께서 굉장히 좋은 발표를 해주신 덕분에 지금 유튜브 라이브에서 굉장히 많은 질문들이 들어왔습니다. 그래서 그 질문들을 먼저 연자분들께 각각 최소 하나씩 질문 드리고, 그 다음에 토론자 선생님들께서 또 질문 있으시면 종합 토론을 한번 이어나가보고, 그 다음에 이제 조금 나중에 마무리를 하면서 각자 발언하시는 이런 순서로 한번 진행을 해보도록 하겠습니다. Okay, so I have actually lots of questions, as you can see. So first, for Dr. Grant Phillips at Trust for America's Health from USA. So Dr. Phillips, we have a bunch of questions for you. So amongst those, I'm gonna ask, I picked one. So the question is, you mentioned the social determinants of health as a factor related to vaccine allocation. So what social factors do you think are the most important in the American community during the pandemic? 한국어로 번역을 하자면, okay, so wait, Dr. Phillips, I will actually translate it into Korean first. 백신 할당과 관련된 요인으로서 건강에 대한 사회적 결정 요인에 대해서 아까 발표에서 언급해 주셨는데, 팬데믹 기간 동안 미국의 커뮤니티에서 어떤 사회적 요인이 가장 중요하다고 생각하십니까?가 질문으로 들어왔습니다. 자, 그럼 코란 필립스 박사님의 답변을 들어보도록 하겠습니다. Dr. Phillips, are you ready to answer?
Yes.
Okay.
So, thank you. That's a great question. I do believe one of the main and initial challenges that we found was transportation. We found that again early on and during the pandemic, transportation became limited. And some of the challenges that we saw immediately is that when vaccines were available, people were not actually able to physically go and get them. They were located in sites and in locations where people may not have access to public transportation. And again, public transportation was already limited due to cuts. A lot of transportation for older adults is volunteer-based or it's run through nonprofit organizations. So if the transportation services were not reduced, they were eliminated. And then public transportation was reduced due to capacity. So there's often, obviously, social distancing needing to happen on buses. So you have limited transportation options. And then you have locations, getting access to those locations. If you have a caregiver in your home, you can't assume that caregiver had access to transportation as well. So transportation, I would say, was probably one of the key issues that we found. And then just overall, some communities did not have close proximity access. So you already had transportation was one. So being the communities themselves necessarily didn't have places that they could go to. So the nearest site to get a vaccine might have been possible. So keeping in mind that liberal communities having access to resources within your designated area, but some of these communities do not have access within their immediate areas. And there's also challenges for healthcare providers to get into communities. I can tell a story about a community, and a lot of our rural communities experience a lot of challenges, but it required the use of a snowplow, emergency services, the local aging sector, and other entities. It took a lot of entities to get together to get vaccine access to a small number of older adults in a rural community. But again, getting them out there, it was challenges with transportation, just general vicinities and access to receive them were two of the main things I would highlight.
Thank you very much for your very detailed answer, and I really appreciate it. And Dr. Phillips, I know it is actually 2 a.m., like almost, like, right? So thank you so much for, it doesn't look like 2 a.m., like your condition looks like just the daytime and all that. So I really appreciate it. So thank you.
It's my honor.
Thank you. 지금 필립스 박사님께서 간단하게 답변을 주셨는데요. 그러니까 굉장히 길게 디테일하게 답변을 영어로 주셨는데 사실 요약하자면 그 백신 할당과 관련된 가장 중요한 요인으로 본인이 생각하는 그런 요인은 그 교통수단이었다고 합니다. 그러니까 미국의 그런 여러 가지 상황을 고려해보고 또 이 뭔가 백신 할당을 하기 위해서 이 교통수단만큼 굉장히 중요한 요인은 없었다고 생각하고 그에 대한 여러 가지 이제 설명을 주셨는데 나중에 이 또 유튜브를 한번 또 다시 보시면서 한번 또 이렇게 닥터 필립스 박사님께서 어떤 말씀을 하셨는지 들어보셔도 좋을 것 같습니다. So thank you so much. So we can actually ask the other presenters. So the questions for Dr. Martin Hyde. So we have also a bunch of questions for Dr. Hyde. I know for Dr. Hyde, it is also it's quite early in the morning, right? So, well, we really appreciate your participation in this early in the morning. And so we have, amongst all these questions I have, okay, so this is the question I'm gonna ask. So the question was, it was very impressive that dementia patients and deaf people were more vulnerable to COVID-19. For this reason, I believe that more efforts will be needed for them to prepare for accidents through regular monitoring. So as far as I know, the social welfare department in the community center monitors not every but some vulnerable older adults regularly in Korea. So I wonder which institutions in the UK monitor their conditions regularly. So hold on your answers. I will actually translate the question into Korean first. So hold on a minute. So 질문은요. 치매 환자와 청각 장애인들이 코로나에 취약한 설문 결과들이 인상 깊습니다. 지금 닥터 하이드 박사님께 지금 드린 질문인데요. 이와 같은 이유로 이들은 평소 주기적 모니터링을 통해서 만약의 사고에 대비하기 위한 노력이 더욱 필요할 것이라고 생각되는데요. 한국에서는 주로 주민센터에서 모두는 아니지만 이와 같이 건강에 더욱 취약한 노인들의 건강과 안부를 주기적으로 관리하는 것으로 이제 저희는 알고 있습니다. 그래서 영국에서는 어떤 기관에서 이들의 건강을 주기적으로 관리하는지 이에 대한 질문이었습니다. Okay, I just translated into Korean. So, Dr. Hayes, whenever you are ready, you can actually answer.
Good morning, Bonada from the UK. So we don't really have the same situation that you have in Korea with the community centres or the daycare facilities where older adults tend to go. In terms of the monitoring of older adults in communities, we have community or district nurses who often visit. One of the big problems we've had in the UK over the last few years, pre-COVID, has been a decline in the workforce, so difficulties in recruiting people into those jobs. So already before COVID, there was a lack of sufficient number of people who were able to do that, particularly in rural areas. So echoing some of the points made by Karen earlier, people in rural areas were hit particularly hard in terms of the impact of COVID. During COVID, with social distancing as well, and the need to maintain social distancing, it was difficult for those healthcare professionals to be able to access patients as they normally would. So there were a number of innovative approaches, people being seen in their gardens was a way, or people being sort of seen outdoors in order to make sure people still got that level of checkup. Aside from that, I'm aware that the fire service in this country also provides a service to check on older adults when they go round, which I don't know if that is something that occurs in other countries, but as a service that provides home safety in terms of fire alarms, they also do a number of other checks about the general living conditions, so whether there are trip and fall hazards in the house, as well as fire hazards. So we have a range of agencies that do that kind of home care monitoring. I think the challenge is, and I sort of do I work closely with our local council, is that it's not always as well joined up as it might be. So individual agencies will often find that there are problems or potential problems with older adults, but that information doesn't necessarily get shared. So a good example at the moment that we're dealing with here at Swansea is the issue of hoarding, so people that acquire lots of materials in their houses. And this is often picked up by agencies under different umbrellas, so mental health agencies, home care, environmental agencies if there's a risk of disease. But there isn't a single place to go to in order for that to be dealt with. And we know that hoarding is an issue that affects older adults in particular. And we know that it's something that increased during the pandemic, I think, as people felt less secure in their lives. So we have a range of agencies that go to people's houses. That was obviously impacted by COVID. And even before COVID, those agencies were overstretched. So it is definitely an issue that has been exacerbated by the pandemic.
Thank you very much for your very helpful answer. So I'm sure the audience would definitely learn a lot from your answers as well. So I will briefly summarize your answers into Korean briefly. Thank you, Dr. Hyde. 지금 닥터 하이드 박사님께서 이 질문에 대한 답변으로 어떻게 말씀하셨냐면 사실은 이 한국의 상황과는 조금 약간 다른 상황이라고, 영국 상황은. 그래서 이제 뭐 어르신들 그런 모니터링 하는 게 사실은 쉽지 않은 이슈고, 그리고 이런 문제를 하기 위해서 저희 같이 뭐 주민센터에서 하는 것처럼 그렇게 똑같이 하는 거는 당연히 아니다. 그래서 이제 여러 에이전시들이, 여러 이제 기관들이 조금 힘을 합쳐서 코로나 전에는 그렇게 해서 이제 모니터링을 해왔다, 이렇게 말씀을 해주셨고요. 근데 그 여러 가지 이제 그런 이런 문제를 조금 뭐 체크업을 하거나 약간 이런 문제에 있어서, 그러니까 사실 농촌에 사는 노인들이 굉장히 어려움을 겪고 있고 약간 이런 부분에 대해서도 좀 말씀을 해주셨고요. 근데 이제 이런 좀 여러 가지 그런 와중에 사실은 코로나가 왔고 이제 코로나 중에 여러 가지 문제가 조금 발생했다, 이렇게 말씀을 해주셨고요. 그리고 이제 이런 모니터링하는 과정 중에서는 단지 그냥 뭐 코로나와 관련된 이런 것뿐만이 아니라 뭐 정신건강과도 관련된 것도 있고 기존의 질병과도 관련된 것도 있고, 그래서 여러 가지를 이렇게 약간 엄브렐라 텀, 그러니까 우산같이 이렇게 굉장히 큰 영역에서 지금 관리를 좀 하고는 있지만 여전히 좀 챌린징한, 굉장히 조금 도전적인 그런 부분이다라고 이렇게 요약을 드릴 수 있겠습니다. 그래서 다시 한번 이렇게 좋은 답변을 주신 하이드 교수님께 감사드립니다. Okay, Dr. Hyde, it was very helpful and thank you very much. Okay, so we have also a question for Dr. Terry Lum. Professor Lum, we have a lot of questions for you as well. Okay, so almost all the questions from the audience, the question I'm gonna ask is the following. So the number of mental health professionals per population lacks in South Korea. That is the current fact. So the audience actually asks you that I wonder what Hong Kong is actually doing and what is like in Hong Kong. Okay, so hold on one moment. I will translate it into Korean briefly. Just to wait, please. Thank you very much. 자, 지금 테리럼 교수님께 질문이 사실 굉장히 많은데 굉장히 또 재미있는 발표를 해주셔서 질문이 굉장히 더 많이 들어온 걸로 제가 파악을 하고 있는데 그 질문 중에 제가 선택한 질문은 지금 이렇습니다. 한국에서는 인구 1인당 정신건강 전문가의 수가 매우 부족한 현실인데요. 홍콩의 상황은 어떤지 이제 궁금하다고 청중께서 질문을 남겨주셨습니다. 자, 그러면 테리럼 교수님의 이제 답변을 한번 들어보도록 하겠습니다. Okay, Professor Lam, whenever you are ready, you can answer to the question.
Yeah. Okay, thank you for the question. Actually, interesting. Hong Kong, I think we will be quite. I guess we'll be quite similar to South Korea. Economically, we are a developed economy. But if you look at the healthcare provider per, for example, 100,000 people, we are more like a developing country, third world country. For example, let me give you some example. In London, per 100,000 population, London has 27.6 psychiatry and 83.9 clinical psychologists. In Tokyo, the number is 23.5 psychiatry, 25.6 clinical psychologists. But in Hong Kong, for 100,000 people, we only have 5.8 psychiatry versus 27.6 in London. We only have 8.7 clinical psychologists versus 83.9 in London. So actually our number is, since Professor Chen is also here, our number is very comparable with Singapore, pretty much the same. Singapore, per 100,000 people, they have 4.6 psychiatry and 9.7 clinical psychologists. So I think it is more like the Asian economy. We are doing well in economic development, but we are catching up, or we are not doing that well in health and mental health, or professionals. So that means for us, we cannot build a mental health system based on specialist-driven model, run by psychiatry or clinical psychology. So right now we are putting a lot of effort to develop what we call is a primary care system for common mental disorder. So in fact, this afternoon, later today, we will have a press conference, to release a major research report on this topic.
Okay, well, thank you very much, Professor Lam. It was very, I would say, given the situation in Korea, I'm somewhat glad to hear your answer in some sense, but also actually, definitely this is definitely better compared to Korea. So, but still we have a lot to go, I think, but it was very helpful. Thank you very much for your answer. 자, 지금 테리럼 교수님께서 굉장히 디테일한, 굉장히 자세한 숫자까지도 이렇게 언급을 해주시는 정도의 그 전문가적인 그 지식을 지금 딱 보여주셨는데요. 뭐라고 요약해서 말씀드리자면 사실 한국보다는 조금 나은 상황이기는 하지만 그럼에도 불구하고 그렇게 썩 좋은 상황은 아니라고, 그러니까 다른 뭔가 질병 관리하거나 약간 이런 분들과 비교를 했을 때는 이제 뭐 이 정신건강 전문가, 특히 사이카이애트리스트라고 하는 그런 분들의 수는 5.8%, 이제 홍콩에서는 5.8%, 그다음에 아까 싱가포르 얘기도 잠깐 이렇게 언급을 해주시면서 싱가포르도 과히 그렇게 다르진 않다, 이제 4.6% 정도 된다. 그러니까 이런 정도로 말씀을 해주시면서 여전히 가야 할 길은 굉장히 멀다. 그래서 이제 뭐 사실 홍콩에서도 이제 나름의 시스템을 도입하기 위해서 여러 가지 노력들을 하고 있다. 약간 이런 식으로 말씀을 해주셨습니다. 그래서 어떤 면에서는 제가 아까 테리럼 교수님께 말씀을 간단하게 드린 것이 사실 한국이 그렇게 좋지 않은 상황이기 때문에 조금 많이 홍콩이 너무 이렇게 막 좋은 상황이면 굉장히 저희도 조금 좋지 않은 그런 생각이 들었을 텐데, 그나마 한국보다는 낫지만 그래도 조금 그런 상황이어서 제가 조금 괜찮다 이런 생각이 든다라고 말씀드렸더니 럼 교수님께서 이렇게 좀 웃으셨는데요. 자, 지금 굉장히 다 좋은 답변을 받았고요. 저희가 이제 두 분의 더 질문을 한번 이제 들어볼 텐데요. 다음은 저희가 이제 싱가포르에서 오신 앤젤릭 찬 교수님께 한번 마이크를 넘겨보겠습니다. Professor Chan, are you there? So, well, thank you very much for your participation. We have a lot of questions for you too. So you can actually check the on YouTube live stream. And given your interesting presentation, the audience asks many questions. So we have actually two questions I can ask. One is some correction related and the fact check sort of thing. So the first question is that you mentioned depressive symptoms decreased during the pandemic in Singapore. Is it true? It decreased or not increased? So that was the question. So hold on a minute. So I will translate into Korean quickly. 저 지금 우리 싱가포르에서 오신 앤젤리크 첸 교수님께 이제 질문이 많이 들어왔는데요. 그 중에 이제 하나 약간 이제 사실 확인에 대한 질문이 있어서 먼저 드리고 이제 조금 디스커션에 관련된 질문을 또 드릴 텐데요. 이제 싱가포르에서 팬데믹 기간 동안 우울증이 이제 감소했다고 이제 발표에서는 이제 프레젠테이션 슬라이드에 언급을 하셨는데 그게 이제 사실인지에 대한 확인 질문이었습니다. Okay, Professor Chan, what do you think?
Okay, well, I happen to know that study. Some colleagues of mine actually did the work. I went back to look at the paper, and they had a couple of explanations why they thought depression decreased over time for this particular group. And one of the explanations they gave was that they interviewed 2/3 of them after the lockdown. So it may have been a case of where they felt that the worst was over and they were feeling a lot better compared to a year ago. So there's a couple things I could have left it out, but then I thought I would leave it in to just kind of raise this issue of survey and data from surveys and sample selection, because the people that agreed to telephone interviews for this project were older people who could hear, were well enough to get on the phone and talk to the interviewers. So we may have been getting a select sample from the get-go. So they had better mental health status than the people that we didn't get. Later on in the paper, they talk about predicting depression in this sample, and it was mainly people with major chronic diseases that were reporting being more depressed. So I think there's an interaction between the number of chronic diseases that an older person has and their depressive symptoms, but they need to do a lot more work to figure out the result, and they concluded that in the article, and they want to do more qualitative work.
Thank you very much. And even your answer was very interesting and intriguing, just to see how to actually interpret this result. And apparently it was true. So the interpretation of your finding is more interesting. So I will actually translate it back to the audience into Korean briefly. Hold on. 지금 찬 박사님께서 뭐라고 말씀해 주셨냐 하면은 이 우울증이 감소했다고 언급했던 것은 사실이라고 이렇게 말씀을 해주셨고요. 이거는 이제 아무래도 이제 데이터 수집할 때 모았던 샘플 이슈가 있었던 것 같다 이렇게 말씀을 해주셨고, 그 이유 중에 하나로 언급하셨던 게 이제 이 3분의 2의 샘플이 저희 코로나 락다운이 지나서 이렇게 약간 인터뷰를 했던 혹시 그 효과가 아닐까라고 이제 좀 생각을 하신다. 그리고 이제 이것이 텔레폰 인터뷰로 진행되었기에 뭐 그런 영향도 있지 않을까 말씀을 주셨고, 그 다음에 어떤 면에서는 약간의 상호작용, 그러니까 약간 그 어르신들이 가지고 있는 질병과 이것들의 이제 상호작용으로 나타난 효과일 수도 있다. 그래서 조금 더 질적인 연구를 수행해봐야지 이런 질문을 좀 알 수 있다. 이런 굉장히 인터레스팅한 질문이 나왔었습니다. 자, 그리고 다음 질문을 하나만 더 이제 드려보도록 하겠는데요. Okay, so the next question for Angelique Chan is what should be considered to better manage chronic diseases through telemedicine. So because you mentioned the telemedicine a couple of times during your presentation, and that actually was very helpful and that was amazing. So that was the question from the audience. So hold on just a second. 지금 두 번째 질문은요, 원격 진료를 통한 만성 관리를 더 잘하기 위해서 어떤 걸 고려해야 하는지에 대한 질문이었습니다. Okay, now actually let's actually turn to you, Dr. Chan. So whenever you are ready, you can actually share your thoughts.
Okay, thank you. One of the things that we found collecting data prior to the COVID lockdown and then during and after in a separate study is that about 42% of older adults delayed their non-essential surgeries. They did not go for rehabilitation. They did not pick up their medicines for those that had chronic diseases. So as much as we tried using telemedicine, there was still a significant proportion of older adults who didn't get the care that they needed during the lockdown. That being said, there were a significant proportion that did. And luckily, Singapore had already been working on telehealth. And so we have the ability at our main hospital, Singapore General Hospital, that sees at least 50% of the population, to use telehealth for consultations and for rehabilitation. So we conducted a lot of medical consultations over the Zoom using internet, and then even rehabilitation, we conducted that over Zoom. That being said, the people who could communicate on Zoom were the older people who had more education or older people who were living with children, and the children were able to set up a Zoom for them and then have them go through either their rehabilitation exercises or help them answer questions that the doctor was asking. So I think we have a long way to go in terms of getting telemedicine used by the majority of older people in the community, because we found that there was still the majority needed help from the younger generation to use these technologies. The incoming baby boomer cohort generation will be different and most likely to use technology a lot more.
Thank you very much, Dr. Chan, and that was very interesting and very helpful to the Korean society as well to help promote our older adults' health as well. So thank you very much. 자, 지금 찬 박사님께서 뭐라고 말씀을 해주셨냐면, 사실 코로나 기간 동안 가장 문제가 됐던 게 이제 진료나 이런 치료에 대한 지연. 그래서 거의 한 42%나 정도 되는 그런 어르신들께서 코로나 기간 동안 이 진료 지연을 했다. 실제로 이렇게 말씀을 하셨다. 그래서 이제 사실 그런 면에 있어서 이제 많은 사람들이 이 텔레헬스를 원격 진료를 하면 이런 만성 관리도 더 할 수 있다. 약간 이런 말씀을 주셨는데요. 그래서 실제로는 이제 이 싱가포르에서는 많은 사람들이 줌이나 혹은 인터넷을 사용한 그런 재활까지도 이렇게 실시하고 있다. 이렇게 말씀을 해주셨고요. 그런데 이제 여기에서 참 첸 교수님께서 말씀해 주셨던 것 중에서 이렇게 사용하는 사람들의 특성을 한번 보니 뭐 교육 수준이 높고 그다음에 집에 뭔가 그러니까 자녀들이 이렇게 있어서 조금 세팅을 도와줄 수 있고 약간 이런 부분에 있어서 이런 분들만 조금 이런 거를 이용하다 보니 조금 문제가 될 수 있고 다른 조금 이용하지 않는 분들에 대한 접근도 좀 필요하겠다. 다만 앞으로는 이제 베이비 부머들이 이제 다시 노년기로 접어들다 보니 이제 앞으로는 조금 더 다른 세상이 열리지 않을까 이런 생각에 대해서도 언급을 해주셨습니다. 굉장히 재미있는 말씀까지도 이게 답변을 통해서도 많이 배울 수 있었던 시간인 것 같습니다. Thank you very much for Dr. Chan's insightful answer. I appreciate it. So our last question for Dr. Che. So Dr. Che is actually participating right here on behalf of Dr. Yasuyuki Gondo. So we have also a couple of questions for you. Dr. Che is luckily he's able to speak Korean, so I don't have to actually translate. So when I ask Dr. Che some questions from the audience, then Dr. Che can answer first in English and then summarize your answer in Korean. 저 지금은 이제 마지막 질문은 저희 이제 최황 박사님께 지금 일본에 계신 야수유키 곤도 박사님과 공동 저자로 이렇게 참여하고 계신 최황 박사님께 이제 마이크를 넘겨드렸는데요. 이제 일본 박사님에 대한 질문도 굉장히 많이 나와서 저희가 이제 질문을 드릴 텐데 최황 박사님께서는 한국 분이시고 그래서 이제 답변은 영어로 먼저 해주시고 그 다음에 한국어로 또 요약해서 발표해 주시기로 하셨습니다. 그래서 질문을 드리겠습니다. 질문은 먼저 영어로 드릴 텐데요. So during the presentation, like the example of karaoke, are there any places older people in Japan get together and interact with each other in Japan? 그래서 질문은요. 노래방의 예시처럼 일본에서 노인분들이 함께 모여서 서로 상호작용하는 또 다른 장소가 있는지에 대한 질문이고요. 최환 박사님께 마이크를 넘겨드리겠습니다.
Okay, with karaoke, Japanese older adults basically gather in local community like neighborhood association, but it was hard to gather after breakout of COVID-19.
네, 최 박사님, 한국어로 간단하게 요약해 주시면 감사하겠습니다. 잘 안 들립니다, 박사님.
노래방과 함께 일본의 고령자들은 자치회와 같은 지역 커뮤니티에서 모입니다. 하지만 코로나19의 발생 이후 모이기 어렵게 되었습니다.
네, 대단히 감사합니다. 그래서 이제 지역 커뮤니티에 모인다 이런 간단한 답변을 이제 주셨습니다. 네, 지금 네, 자 그러면 저희가 이제 어디언스로부터의 질문은 다 끝났고요. Okay, so we are done for the questions from the audience. So I now ask the discussant whether the discussants have some particular questions to our wonderful presenters. So do you have any questions, Dr. Kim, Dr. John, and Dr. Won? 자, 지금 질문이 혹시 우리 디스커션 해주신 토론자 선생님들께서 혹시 질문이 있으신지 제가 여쭤봤고요. 지금 한번 질문을 기다려보고 만약에 질문이 없으시면 저희가 이제 컨클루딩 리마크로 가도록 할 텐데요. 질문이 있으실 것 같습니다.
이제 외국에서 이제 우리가 코로나를 경험한 고령층은 많이 시행착오를 겪었잖아요. 그래서 만약에 유사한 아웃브레이크 바이러스가 오면은 그 과거의 정책을 시행한 걸 바탕으로 볼 적에 어떤 것들은 좀 더 우리가 더 고쳐서 얼터너티브로 하는 게 바람직한지. 그러니까 사실 셧다운은 너무 쉽고 근본적이긴 하지만 되게 여러 가지 문제가 있기 때문에 그런 혹시 트라이얼 에러를 통해서 좀 더 바꾸고 싶은 그런 것들이 있는지 그런 것들을 좀 물어봐 주십시오.
Okay, so Professor John asked the presenters in terms of, so the pandemic, this pandemic probably is not the end. So we may have some another pandemic, who knows, right? So when the pandemic comes in the future, not just the things that we normally did during this pandemic, what other policies we can actually adopt and we can develop or we can use to cope with the next pandemic? Is there any thought? So that was the question. Any presenters who wants to answer? Okay, so Dr. Hyde 박사님께서 지금 손을 들어주셨습니다.
I think one of the few positives that have come out of the pandemic has been the rise of community groups and the awareness of sort of community resilience, and certainly the finding that having a diverse area where you live. So you're not solely dependent on just to have it. If you just live in a housing area with no local amenities, you are much more vulnerable. Again, as Karen said, in relation to the US, communities that were disconnected from transport, who often had to rely on volunteers, were able to survive for a part, but then as social distancing came in, they lost those lifelines. So I certainly think that one of the big takeaways for me in the UK context, at least, is to build more resilient communities, particularly around ensuring that there is a diverse range of goods and services within 5 miles, 20 minutes of the house, so that people weren't disconnected from those big metropolitan areas, which were more and more difficult to get to, and therefore they were unable to access their medicines, unable to access food and essential services. So I think that for me is one of the ways that we can be better prepared for when the next pandemic comes.
Thank you very much, Dr. Hyde. 닥터 하이드 박사님께서 뭐라고 말씀해 주셨냐면, 그래도 여러 가지 이제 요소들이 있겠지만 그래도 가장 중요한 것은 이 회복 탄력성에 대해서 강조를 해주시면서 회복 탄력성이 높은 지역 사회를 만드는 것이 굉장히 필요하겠다, 이런 말씀을 해주셨습니다. 굉장히 좋은 코멘트였고요. Okay, that was a very helpful comment. Any other presenters?
Yes.
Dr. Phillips? Okay, Dr. Phillips?
So we like to refer to the pandemic as, it's obviously it's unfortunate, but it was a catalyst to bring about some really innovative solutions. My area is age-friendly public health, and public health has not always been a partner in addressing aging services, but public health is now at the table, and public health is now able to partner with the aging sector to provide better access to nutrition programs, better access to social engagement resources. So I think one of the key things that we thankfully have seen plans for people and organizations to continue are these partnerships to bring about more opportunities, more social engagement, more distribution of resources and services and programs. So I'm hoping, and I think we're going to continue to see that there's a better alignment of programs and more opportunities to better align these different resources. I think, and I'm not fully an expert on telehealth, but I think telehealth, broadband access was a challenge. Broadband access was a challenge, especially in our rural communities. And we're thankfully starting to hone in on that. And there have been programs that are providing better broadband access in rural areas and across the country as well. We know that at least you can provide access to health and different social engagement resources via telehealth as well. So that is something that at least if we find ourselves in another challenge where we have to shut down, people have at least better access to telehealth, and then potentially even more access to services and resources in their communities. And I should have mentioned this earlier, it's a better health equity lens, because we're also reaching out and engaging and supporting all communities, not just those that already had access, but we're trying to take a better approach to promoting more health equity.
Thank you very much, Dr. Phillips. It was very helpful, and definitely it is in line with your presentation you already shared earlier. 자, 지금 코란 필릭스 박사님께서 굉장히 좀 여러 가지 말씀해 주셨는데, 그 중에서 저희가 코로나를 겪으면서 새로운 해법들에 대한 가능성을 엿보았다, 이렇게 말씀을 해 주셨어요. 또 특히 이런 공중보건과 관련된 이슈를 저희가 이제 좀 타겟을 해서 보면은, 그러니까 여러 가지들을 이제 저희가 할 수 있다, 약간 이런 것들을 엿보았는데, 그 중에서 이제 여러 그런 것들, 자원들에 대한 이용을 조금 더 용이하게 하는 데 있어서 이 텔레헬스, 즉 이 원격 진료에 대한 그런 가능성을 좀 많이 언급을 해주셨습니다. 그래서 굉장히 좀 좋은 질문이었고, 사실 우리가 앞으로 조금 나아가야 할 방향도 저희 한국에서도 그런 방향이 돼야 되지 않을까, 이런 생각도 저도 이제 살짝 덧붙여 보았는데요. 굉장히 도움이 많이 되는 그런 답변이었던 것 같습니다. Thank you, Dr. Phillips, again. Any other presenters who wants to actually join this discussion? Okay, Dr. Long first and then Dr. Chan.
Okay, maybe I can share a little bit the experience we have in Hong Kong. I think we did extremely well in the first 2 years of the pandemic, mainly because we prepared well. We learned a really painful lesson in the SARS epidemic in 2003 that hit our nursing home extremely bad. So we learned that for nursing home population, the transmission route is mainly from hospital to nursing home. So at the very beginning of the pandemic in 2020, we immediately stopped that route. So we do not allow, for example, the physician from hospital visit the nursing home. We also did not send the patient to the hospital for follow-up unless it is really urgent cases. So we were able to keep the infection rate in Hong Kong, particularly nursing home, extremely low. So it was 1.5 years after the beginning of the pandemic, we had the first nursing home outbreak. So we have 1.5 years without a single nursing home outbreak in Hong Kong. So this is quite extraordinary. Number 2 is also because of 2003 SARS epidemic, the government required all nursing homes to have one nurse designated as infectious control officer. And the government provides training for that person. So, and that person also implement the infectious control policy within the nursing home. So, for example, all nursing home staff, they know about how to use chemical to disinfect area. The government also required they have 3 months storage of personal protective gear and chemical within nursing home. So it gives us a breathing room when the pandemic first hit Hong Kong, that they are able to isolate the nursing home residents from the virus. But then we fell badly in the early this year, mainly because our policy did not change based on the change in the pandemic. So when we have the vaccine, when we have the antivirus drug, we should start opening up a little bit, and also instead of using a very closed loop system. For the closed loop system, the good thing is we are able to protect older people. The downside is the older people feel secure and they did not go to vaccination. So we have very low vaccination rates among older people. So when the Omicron comes, it hit us really badly. So we jumped from one of the best cases in the world to one of the worst cases in the world in 2 months in terms of death due to vaccine. So I think the second lesson is the government really needs to change the policy and the strategy based on the changing available of resources like the vaccination and the drug and the change in the virus. So I think it was also a really painful lesson we learned in the last few months that we jumped from only a couple hundred of people died in 2 years to more than 10,000 of people dead just in 1 month. So we add something like 99% more people died in less than 1 month, mainly due to the failure in the policy because of the changing of the Omicron, which is much higher infection rate as well as the failure to change the policy. So let me stop here.
Okay, thank you very much, Dr. Lam. It was very helpful to, we already learned from all these experiences and you shared those and also what we need to do and what we need to consider. So that was very helpful. To summarize in Korean, 잠시 제가 한국말로 잠시 이제 럼 교수님의 말씀을 잠시 요약드리자면은 사실 아까 럼 교수님께서 발표 중에 그 SARS 바이러스가 옛날에 홍콩에 이렇게 상륙하고 그래서 도달했을 때 그때의 경험도 이렇게 살짝 얘기를 해주시고, 근데 결국에는 이 백신을 어르신들이 좀 이렇게 맞는 비율이 굉장히 낮았고 약간 그럼으로써 이제 어르신들이 이렇게 약간 많이 사망률도 높았고 약간 그런 경험을 조금 말씀을 해주시면서 이제 백신을 어떻게 하면 조금 더 잘 이렇게 맞게 해주실 수 있는 그런 시스템으로 우리가 좀 정책에 대한 변화 이런 거를 조금 고려해야 되지 않을까, 그러면서 이제 여러 가지 경험에 대해서 홍콩의 경험과 사례에 대해서 말씀해 주셨습니다. 굉장히 도움이 많이 되는 답변이었고요. 아까 닥터 찬이 좀 손을 들어주셔서 지금 이제 마이크를 그러면은 chen 교수님께 한번 넘겨서 간단한 답변을 한번 들어보도록 하겠습니다. Okay, so now Professor Chan, I know actually you raised your hand earlier, so now it's your turn.
Yeah, I just wanted to comment. that if when the next pandemic hits, what this situation taught us is that we need to really be aware of those groups that we are not often seen. And what I mean here are migrant workers. So Singapore locked down immediately after we got a case. And everybody thought, well, we're going to do great. But they forgot that migrant workers live in dormitories, and that one case in a dormitory, it spread like wildfire. And that was when we really had to, help foreign workers, mainly in construction, to get our numbers back down again. So I guess the idea that we need to, no one gets left behind, and looking at health inequalities is something that this situation taught us.
Thank you very much, Dr. Chan. I'm actually thinking about that particular population that we need to focus, and that is certainly in Korea. We have a lot now. We have more migration population is coming, and it is actually slightly increasing over and over. So in that sense, it was a very helpful comments and the discussion point that we need to think about in the future. So thank you. And to summarize in Korean briefly, 지금 찬 박사님께서 굉장히 좀 좋은 포인트를 말씀을 해주셨는데, 우리가 평소에 조금 주목하지 않는 이런 팬데믹 시기에 주목하지 않는 그런 집단에도 조금 관심을 가져야 될 필요성을 많이 느끼셨다, 이런 포인트를 말씀해 주시면서 특히 말씀해 주셨던 그 집단이 이주 노동자들입니다. 그래서 이제 싱가포르에도 굉장히 그런 인구들이 많고, 그런데 이제 예를 들어서 한 명의 이주 노동자가 기숙사에 사는 경우 이제 굉장히 여러 사람이 감염이 되는 그런 위험에 처하게 되죠. 그래서 그런 부분에 대해서 말씀을 간단하게 해주셨습니다. 자, 그래서 굉장히 좋은 포인트였던 것 같고요. Any other? So I think it was a very fruitful discussion based upon Dr. John's question. Okay, so now it's already like 5:10. We are supposed to end at 5. I couldn't stop because it was really fruitful discussion of that. So I know a lot of questions to come from our wonderful discussions from Dr. Kim, Dr. John, and Dr. Won. But given the limited time and we are all over the time, so now I will actually back to you all for some very brief concluding remarks. So I know you have like something to say, you wanted to say something, so just one sentence, like any final and concluding remarks from all our speakers and discussants. So anyone wants to do first? 자, 지금 저희가 이제 시간이 굉장히 지금 원래 5시에 끝나야 되는데 5시 10분이 되었습니다. 근데 굉장히 풍성한 디스커션이 이어지고 있어서 제가 이렇게 시간을 탁 이렇게 끊기가 굉장히 힘들었습니다. 하지만 그래도 이 굉장히 오늘 귀한 시간 내주셔서 전 세계에 계신 분들께서 이렇게 한 자리에 모여서 풍성한 디스커션을 이어가고 있는데, 다음 팬데믹을 준비한다고 하기에는 좀 그렇지만 뭔가 대비하기 위한 이런 시도로서 굉장히 좋은 시간이 장인 것 같습니다. 그래서 저희가 이제 마무리를 함에 있어 여기 지금 토론자 선생님들과 그 다음에 발제를 맡아주신 우리 연자 선생님들께 마지막 한 말씀을 제가 이제 부탁을 드렸고요. 자, 지금 8분께서 아주 간단하게 한마디씩 하시고 나면 저희가 이제 이번 심포지엄을 마무리하게 될 것입니다. 자, 그러면 어떤 분께서 먼저 말씀을 해주실까요? Anyone wants to do first? In terms of your final and concluding remarks? Okay, Professor Chan.
Okay, I'll go first.
Okay.
One sentence. I think we need to improve health literacy of older adults. And this relates to vaccine take-up rates and the use of telehealth and the importance of managing chronic conditions.
Thank you very much. 문해력을 향상해야 된다. 이렇게 간단하게 말씀을 해주셨습니다. Okay, Professor Lam.
Yeah, I think effective public health communication are extremely important in a pandemic particularly there is so much misinformation about the vaccine, about the risk of that, but I don't think we are up to the point, in the last few years to have a very effective and transparent public health communication, at least not in my society.
Thank you very much, Dr. Lum. So Dr. Lum, 죄송합니다. 지금 럼 교수님께서 뭐라고 한마디로 말씀을 해주셨냐면 굉장히 효과적인 공중보건 커뮤니케이션이 필요하다 이렇게 말씀을 해주셨습니다. Thank you, Dr. Lum. Okay, Dr. Hyde first.
Yeah, I think just to echo as well what other speakers have said, that the pandemic has clearly exposed a number of deep-seated inequalities in our countries and the ineffectiveness of existing policy instruments to address those. But it's also given us lots of positive examples of where community groups have come together to work positively. And I think one of the other outcomes that I think we need to ensure that we don't lose is the tremendous work of the international academic and research community to come together and share information, share data, work in a more open science way, so that hopefully we can learn from each other. So some of the speakers here today have given me great ideas to take back to my group and continue in that spirit of open cooperation to be better prepared for the future pandemics, whatever they may look like.
Oh, thank you very much, Dr. Dr. Hyde, thank you very much. 지금 Dr. Hyde 박사님께서 되게 이제 이전에 말씀하셨던 이 연자분들의 굉장히 동의한다 그러면서 우리가 이제 그 커뮤니티를 조금 더 건강하게 만들어야지 앞으로 더 대비할 수 있다. 이런 커뮤니티의 긍정성의 중요성에 대해서 말씀을 해주셨습니다. Thank you, Dr. Hyde. 네, 원시연 박사님, Dr. Won.
Today, I just focused on the vulnerability of the elderly, but from now on, I will balance the strength and the weakness of the elderly for the more better laws for Koreans.
Okay. 한국어로 간단하게 해주실 수 있을까요?
제가 오늘은 그 한국 노인들의 그 취약한 점에 대해서만 좀 강조를 해서 말씀을 드렸는데 앞으로는 한국 노인들의 장점과 또 약점을 모두 다 밸런스를 맞춰서 연구해서 그것이 좋은 법률이 되도록 노력하겠습니다. 감사합니다.
Thank you very much, Dr. Won, and that was very helpful comment. 자, 원 박사님께서 굉장히 본인의 그 소임에 맞는 그런 코멘트를 해주셨고요. 자, 또 다른 박사님, anyone wants to make? Okay, Dr. Che.
Thank you for giving us great chance to share opinions on our study, and it was time for me personally to study many things about older adults after COVID-19 breakout. 그래서 연구에 대한 의견을 공유할 훌륭하게 해주셔서 감사합니다. 그리고 개인적으로 코로나19 발발 이후에 고려자에 관한 많은 것들을 배울 수 있는 시간이었다고 생각합니다. 감사합니다.
Thank you very much, Dr. Che. 지금 최 박사님께서는 한국어와 영어를 동시에 이렇게 말씀을 해주셔서 대단히 감사합니다. Anyone? Dr. Phillips?
Just echoing also what all the other great speakers have shared, and something that Dr. Chen said about the communities that were isolated, making sure that we have equitable access to whatever resources we produce and we develop in all of our communities.
Thank you very much, Dr. Phillips. 지금 아까 Dr. 최한 박사님께서 말씀하셨던 거에 이렇게 동의를 해주시면서 조금 더 이렇게 형평성 있는 그런 접근이 필요하다 이렇게 말씀해 주셨습니다.
Yeah, I will go with.
Okay, Dr.
Yeah, thanks for the meaningful comments. I totally agree with all the participants. And I think strengthening workforce is very important, and also use ICT for improving effectiveness and also equity. And last but not least is the governance. It's very important. So I hope we will continue to work on to better support our elderly population. Thank you.
감사합니다. 교수님 한국말로 간단하게 우리 한국에
네.
계신 어디언스를 위해서 간단하게 요약해 주실 수 있을까요?
네, 인력을 더 돕는 것, 그러니까 돌보는 인력들에 대한 강화, 그리고 테크놀로지를 서비스 효과와 동시에 또 그 형평을 높이기 위해 사용하는 것, 그리고 거버넌스를 더 강화하는 것, 세 가지에 대해서 말씀드렸습니다. 좌장님 또 모든 참여자들 수고 많으셨습니다. 감사합니다.
네, 감사합니다. 김홍수 교수님. Thank you very much, Dr. Kim. So now we have only one discussant actually left. So Dr. John.
Yeah, thank you very much. I would like to say that we have to advance our community care system, and at the same time we have to actively support human relationship of all the people. Thank you. 네, 그 우리나라의 상황을 생각할 때에는 커뮤니티 케어 시스템들을 제대로 만드는 것이 너무 중요하고, 특히 아까 말씀드린 것처럼 노인들의 어떤 인간 관계망들을 잘 확대하고 유지할 수 있도록 지원하는 것들이 매우 중요한 것 같습니다. 감사합니다.
Okay, well, thank you very much, Dr. John. 예, 대단히 감사합니다, 전 교수님. 이것으로 모든 지금 토론, 종합 토론과 Q&A 세션은 아쉽게도 지금 이렇게 시간이 조금 지나긴 했지만 마무리해야 될 것 같습니다. 그래서 제가 이제 와주신 연자분들과 토론자 선생님들께 감사의 인사를 전해드리고 저희가 이제 마무리를 하도록 하겠습니다. 잠시만 기다려 주십시오. Okay, well, thank you very much for all of your efforts and hard work. And also, I know it was very hard to actually just maintain from the early this afternoon to all the way to like this late afternoon here in Korea. So it was indeed a very fruitful discussion, I believe. So now, I just appreciate all the participants today for the symposium. Definitely, without you, it was not possible. So I'll contact you. So stay tuned. So we'll actually conclude the overall discussion and question session. So thank you very much again. Bye-bye, everyone.
Thank you.
네, 대단히 감사합니다. 지금 이렇게 참석해 주신 여러분께 제가 인사를 나눴고요. 자, 이제 마무리를 하도록 하겠습니다. Okay, so we are done for the major program for the program for today we prepared. So thank you for attending the live streamed symposium hosted by Korean Gerontological Society and supported by Seoul Metropolitan Government. We really appreciate your interest in this very important topic. Audience, you can ask further questions to the panelists and presenters via email. You have the email addresses. So let me close the symposium, the program, main program, with thanking our wonderful distinguished presenters and discussants from all over the country. And also, I also thank our KGS President, Professor Kim-Yong Lee, and also Seoul Metropolitan Government, and also other Korean Gerontological Society related personnel. I really appreciate it. Thank you very much. 오늘 온라인 생중계로 진행된 한국노년학회가 주관하고 서울시가 후원하는 국제학술 심포지엄에 참석해 주신 여러분께 이 프로그램의 좌장으로서 대단히 여러분께 감사드립니다. 이런 시의적절하고 굉장히 중요한 문제에 관심을 가져주셔서 대단히 감사하고요. 해외 연자들을 모시고 여러 국가의 사례에 대해서 배우고 또 국내 전문가 패널 분들을 모시고 포스트 팬데믹 시대를 준비하는 데 있어 어르신 복지를 위해서 서울시 그리고 대한민국이 나아가야 할 사항과 또 앞으로 나아가야 할 방향에 대해서 배울 수 있는 굉장히 뜻깊은 시간이었다고 좌장으로서 감히 말씀드리겠습니다. 다시 한번 심포지엄에 참여해서 풍성한 논의의 장을 마련해 주신 5개국의 연사님들과 국내 토론자 선생님들께 진심으로 감사를 표하면서 포스트 팬데믹 시대에 새로운 노인의 삶이라는 주제로 진행한 심포지엄 세션을 마치도록 하겠습니다. 그래서 오늘 이 자리에 와주신 한국노년학회 이금용 회장님, 총무이사이신 이상우 교수님, 그리고 다른 저희 노년학회 학회 관계자 부회장님들 여러분 다들 너무 감사드리고요. 다시 한번 지원해 주신 서울특별시 대단히 감사드립니다. 다시 이번에 이제 제가 세션은 마무리하고요. 심포지엄의 사회자이신 한국노년학회 총무이사 이상우 교수님께 마이크를 넘겨드리도록 하겠습니다. 여러분 감사합니다.
네, 그럼 이것으로 오늘 제16회 서울노년학국제학술 심포지엄 포스트 팬데믹 시대 노인의 삶, 새로운 도전과 기회라는 주제로 열었던 모든 행사를 마치도록 하겠습니다. 긴 시간 동안 참여해 주신 모든 청중과 발표자 그리고 토론자 분께 감사드립니다. 특히 오늘 좌장을 맡아주시면서 모든 행사의 어떤 토론과 발표 내용에 대한 요약과 그리고 통역까지 주로 맡아주신 우리 대외협력 부회장님이신 중앙대학교 심리학과 김기현 교수님께 진심으로 감사드립니다. 네, 그럼 이것으로 오늘 행사를 마치도록 하겠습니다. 감사합니다.